Good morning, ladies and gentlemen. My name is Pachari. I'm a representative from Olympus. This is my great honor to be the MC for today. Welcome all of you to join our course today, MESDA Smart Surgeon and Smart Exposure course. Our program today will include topics that could be essential for you to overcome inconvenience encountered in working the condition both for clinical and non-clinical matters. Today, we have invited the world-class faculty from Japan, Vietnam, and Thailand to share wonderful experience with you. And we do believe that all the useful and smart tips today that we'll be sharing in today's section will bring advantage to your daily practices. Before we start the programs, I would like to share with you the video from Professor Kitano. He's the president of MESDA for the opening remarks.
Good morning. On behalf of MESDA, I would like to say a few words at the opening of this course as a chairman of MESDA. Welcome to our MESDA webinar, Smart Surgeon, Smart Exposure today. MESDA has been conducting the training course. We established in 2016 and we reached to 17th workshop as of July this year. This time we have ad hoc online event separate from our continuing workshop. I would like to say thank you to the course director, Dr. Siripong Chewatanakornkul, and Assistant Professor Voraboot, Taweerutchana. And thank you for joining the international faculties, Professor Ichiro Takemasa and Dr. Kaz Zunori-sama from Japan, and the local faculties from Thailand for giving your lectures today. I'm so grateful and proud that there have been so many young surgeons well trained so far, more than 700 trainees from Mekong regions such as Cambodia, Laos, Myanmar, Thailand, and Vietnam in the field of endoscopic surgery with the various areas. I hope we all can learn a lot from the expert of the surgery, rectal cancer surgery, and obtain new knowledge and skills from them. Okay? Let's get started.
And next, may I invite Associate Professor Vitun Chinsawangwatanakul, our chairman of MESDA, to deliver a welcome speech. Professor Vitun, please.
Thank you. Good morning, everybody. On behalf of MESDA Local Organizing Committee in Thailand, I would like to welcome all your participants today. Actually, this event will be another kind of our activity after all of us have to struggle with the COVID-19 pandemic for nearly 2 years. As you all know, we have to change our way of life, and I hope this change not only going to be the new normal or next normal. I believe that it will never be normal at all in the future. So we have to adapt ourselves. We have to change the way we do our academic activity. As Professor Kitano already mentioned, that MESDA have already established nowadays it's actually should be the 5th year anniversary, since July 2021. We expect to set up over 20 or 25 workshops so far. Anyway, we do not stop our attempt and our academic mind. We believe that all of our academic organization committee will do their best to convey the new normal or next normal academic activity of MESDA to all of us in the future. And this activity today, Smart Surgeon, Smart Exposure, will be another new kind that we combine not only the activity on the academic, on the technical skill, but we also believe that the more common of the soft skill more important to all surgeons as well. So I hope all your participants today will enjoy our activity. Thank you very much.
Thank you, Professor Vitun, for the great welcome speech. All attendees at the chat window in Zoom programs and comment box in the MESDA Facebook Live are available for any questions that you may have during our call today. Our moderator in each section will pick up your question and ask speaker to address them accordingly. So for starting the section today, I would like briefly the course that we including the clinicals and non-clinicals. So the non-clinical is will focus for the several issues that is very, very interested part. And we think that this course is quite challenging and fun for all the doctors, all the surgeons. So, and then I will pleasure to invite Professor Siripong Chewatanakornkul from Songkla Nakarin Hospital, Prince of Songkla University, and Assistant Professor Voraboot, Taweerutchana from Sirilas Hospital, Mahidol University, as our moderator for the first section today. Before I transfer the microphone to them, so we would like to thank you very much, and please enjoy our course today, MESDA Smart Surgeon and Smart Exposure. Thank you.
Hi, สวัสดีครับ Good morning, everybody. Good morning, everyone. I would like to welcome all of you to the MESDA course today. So my name is Dr. Siripong. So right now I'm with Dr. Voraboot.
Hi, good morning, everyone. Hi, Dr. Siripong. How are you?
Good to see you today.
Good.
So
yeah, it's my pleasure to be the moderator with you this morning.
Oh, thank you so much. Thank you so much.
And,
so we are.
Welcome all the participants today to our interesting meeting. All right.
So I think first of all, we would like to thank Professor Kitano and Dr. Vitun for providing us the great opportunity to be organized this MESDA course. And we also like to thank our main sponsor, Olympus, and the Medtronic company to support us to be establish the conference today. And the most important, we would like to thank all of speaker and participants from the Mekong area, including the Southeast Asia, Bangladesh, Cambodia, Hong Kong, Indonesia, Japan, Libya, Malaysia, Myanmar, Philippines, Singapore, Sri Lanka, Thailand, Turkey, and Vietnam to be here with us today. Thank you all participants. So I think Dr. Voraboot, can you give us a little bit about the scope of the lecture in the morning, please?
Yeah, sure. All right. This meeting gonna be focused on non-clinical skill in the morning, which I think it's very important and essential to any young trainee who wanna be a great surgeon, a charming, a perfect surgeon. I think this kind of lecture is very difficult to be attended. I think it's such a great opportunity for us to listen to the talks from our experts today. The topic including today, this morning, including how to become a great public speaker, and how to become a skillful MS surgeon, how to write a good manuscript and get published, and also English for surgeon is. I think this part is very interesting because most of us sometimes think we have a really good English already, but actually you didn't speak like correctly. So it's a great opportunity to learn from the expert. Okay, and also how to make your video clip attractive, and also finally how to write your operative note just into one single simple illustration. Okay, so I think I can't wait to listen to our talks this morning.
Oh, it sounds very interesting. It sounds really cool.
Yeah.
Right? Yeah. So after the first session in the morning, we have some few topics in the afternoon. We will go over the critical view of safety, how to make a right exposure in minimally invasive surgery, including in lap chole, in TAP or TAP, in right hemicolectomy, or in left colon resection or lower tibial resection. I think today all of the participants will get a lot of opportunity and benefit from our lecture. Okay, let's. Okay, before we are going to the first speaker, I would like you to, if you have a comment or if you want to send us some emoji or some icon or love or like, you can put it in our Facebook Live, Facebook MESDA, or Facebook the Blue Theater on the internet. Okay, shall we move to our first session now, Dr. Voraboot?
Yeah, let's rock and roll. Let's start.
Okay, so the first speaker, I think, will be Dr. Sutep. I believe that everybody here already know who he is. Professor Sutep Udom He is currently in director of Juฬาminimally invasive surgery. He also is the president of Thailand Laparoscopic Endoscopic Surgery of Thailand, and also the president of ELSA. I think we all recognize him as a big brother and a pioneer in the field of minimally invasive and bariatric surgery. He has experience in give many lectures and live demonstration, including the speech. So today we have a good opportunity to be, he will give us about the tip and trick for our public, how to becoming a good public speaker. So please accept our greeting, Professor Sutep Udom Swangsap.
Thank you. ขอบคุณมากครับ Thank you very much, Siripong and Voraboot for the introduction. I emphasize that today the program of MESDA will be very attractive. But you have to follow from the first minute to the last, so then you won't miss anything. So please follow us. And today I feel like a little bit excited because as you may know that giving a talk on surgical field, it's not easy, but it's quite comfortable for us. But now today I give a big job. Thank you very much. It's great honor to accept the invitation to give a talk on how to be a great public speaker, which I think as a surgeon, I'm still learning to make it more efficient. So that I think for having an opportunity to review for how to be a great public speaker, it's one of my reward for this moment that I appreciate it very much. If I give you an example, I think from the first the president of MESDA, Professor Kitano, has been already giving you an example of how to give a public speech nicely. So I think you can rewind and you can review from my kind of effort to put it together. But Professor Kitano has been already give you a good example. And also Professor Vitun, our leader in the MIS and also in surgical field. So you can see that how he given his speech nicely. So thank you very much. And Ohayo gozaimasu to Japan. You can see, you can learn from all speakers. They're also a good and very nice public speaker. So let me share my slides and then we will get through the talk that I've been given. Thank you very much. I think it's my great honor to be giving a talk on public, how to be a great public speaker. And you will see that today my slide will be very simple because I would like you to see what the content is. As I mentioned earlier, I'm still on the way to be a better public speaker. So then we learn together. So I think first thing to be emphasized is that how important of the speech, how it is important. For us, the skill to do the operation, it's very mandatory for us to be a good surgeon. So as same on the other side, I think if you would like to be a good public speaker, you have to know that how important the speech is. So you can see that speech have a tremendous power. You can unite people by your speech. And also you can change or you can attain your goal from your friends or your colleague, not only in your business, but also in your life. So I think this is the main and a very important talk for today. Speech is very, very important. Like our surgical skill and our philosophy of treating other patients is also very important. So this is the same thing, but if you have a look into this part, we as a surgeon, we are humans, so don't worry. You will be very, very much to be worried in front of people. This is what we are as a human, so that's okay. But we need to practice. Similarly to when you start first cholecystectomy laparoscopically, same thing, you feel very uncomfortable. And when you practice more, it becomes more and more comfortable and the result is more beneficial to the patient. What we have to do as a surgeon, we need to fix the problem that a patient has. To give a speech, you have to go to your speech clearly. It needs to be clearly. If you would like to inspire people, if you like to, you have to fix it very clearly what you want to say. If not, it's very difficult to get to that point. And also it's important that you just guide the audience, lead them, and then let them discover by themselves. This is the key of giving a speech. So let them discover, let them accept that, let them get the point that you're going to give to them. Now I become more practical. So how to become an awesome public speaker? I would say to be better and better every day. We'll keep learning. Number one, exactly, when you got the topics, when you got the opportunity, you have to research the topics. Very much important that if you got the point that you have been already familiarized with, that might not be too difficult. If some part that you are not comfortable with, you have to be very much being familiarized with, very much. Your vast of knowledge to give your topic, give you the confidence. When you have confidence, you have authority to give your speech and you get the audience to the point that you would like them to be. Number two, when you give a speech, you need to know that why the opportunity comes to you. So, number one, you would inspire people. That's very important. You have to know. Or you're going to entertain people. You're going to persuade something. you're going to provoke some idea or something. This all you have to understand very well before we prepare. Before you prepare, you have to prepare, you have to practice, and then you get to the point that you're going to do. If you don't clear the reason so that the audience themselves will say what they have to listen to you. So this is very important of the point. Number 3, as a surgeons, as a people, as a human, we have to practice, practice, and practice. You will listen to our master in suturing, they practice, practice, and practice. You want to be a great public speaker, you have to also practice. How to practice? For laparoscopic surgery, you get yourself into the box, you do several things, but for the public speech, get in front of the mirror. During the shower time, speak out loudly, and then try to get yourself comfortable. So this is what we have done. I think we as a surgeon, we have practiced our way of getting ourselves skillful. Skill to practice for speech is also a thing that we need to do. And also you may have to give a speech in front of people, in front of your family, so then you can get your feedback. This is also very important. Sometimes you thought that the audience would be getting the point, but sometimes not. So you have to give a practice in front of people, the one that you are very close with, so then they can give you advice. Practice is not meaning that you memorize all things that you're going to give a speech. That is not correct. You just make yourself comfortable with, remember, do not memorize it. You have to understand it. Then you give a speech, and then you know the flow, you know the heading that you're going to have. So this is important. Not memorize, but understand and know what you're going to flow the idea to be. Number 4, very important. This morning you can see that our president, Professor Gitano, Professor Vitun have been already giving you a welcome. We also, when you get started, welcome. It's very important to connect the speaker and the audience. So it's very important. This is the communication. This is the interaction. So you have to have a warm welcome that will calm your nerve down. You feel more comfortable, and then you get the attention from the audience. So this is also very, very important. Basic, but very important. Number 5, of course, you have to know your audience. Who's going to be your audience? Who's going to be in the group of those who are sitting in front of you? It is very important. And also the emotion or the address them. You have to address them properly. Now I don't have anyone. This is the difficulty of giving speech or giving a talk in front of computer. But anyway, try to make it comfortable. Then one day you're going to have that, and you get directly to their interest, their goal, or their need. So this is what it needs to be. Before it gets started, probably sometime we get there early, we can mingle with them, you can be familiarized with them, find needs, warm smile from them. All these will make big difference. So that get there earlier, get yourself comfortable with them. This is also part of the practice, part of the do that we have to do. Very importantly, get the audience involved. Get them involved, that would help very much, I can tell you. Number 6, try to get them, lead them to the imaginary as much as you can, so then they can follow, not too difficult. So this is very, very important. You can attend the audience, maintain the attendance, use a stronger word, or you can use a picture that they can get into their mind. So it's very powerful concept that they can get. And you can focus on the theme that you're going to get them through. You can use lines, or you can use some very, very familiarized word that you give to them, so then they can follow. This is also very important. I have seen several of the speakers. They are very good in visualize themselves as to give an epic speech. So this is very important. Try to make yourself comfortable. Try to make yourself like you are giving a speech of your dreams. So this is very, very beneficial, and that would give you confidence. and also it will reinforce your speech. If you give an amazing talk, then the audience will live for that event too. So this is always very, very important. Then it's time for you to get on a stage giving your talk, all that you would give to them. Finally, you have to end very, very strong. This is the most important, to get all of the audience to the point that you would like them to be, to pursue or to get the change that you will get from them. So there has to be very, very strong ending. Then the point will be discovered by the audience. Then if you give a very strong ending, so you can see that the message will be getting to our audience. So this is also very important. So let's see. I have introduced to you already that you can see from our president, Professor Gitano, or you can see from Prof.Voraboot. They give a speech at the beginning, a warm welcome, and also they give the all point to you already. So this is also one of the great example. But let's see, if you would like to see what is the very strong and very nice speech, let me bring you to another presentation. Let's see, I'll bring you there for the example. Let me stop this sharing a bit, and then I share another one that will show to you. Let's see how we get there. Yes, of course. I have probably 5 more minutes to go with this show. Sorry, I have to stop sharing. Try one more time. Okay, sorry, I think it's not working well for me. This is also, let's see how we go the other one. Okay, let's try it's working or not.
This program is brought to you by Stanford University. Please visit us at stanford.edu.
What about it's presented over there nicely or not?
It's not presenting, Dr. Sirip.
Okay, sorry. Let me stop sharing this one. Sorry for some technical issue. It's also part of the learning that we have to check again. Look, let's see one more time. I would say it's gonna be the last one. Is it working? No, I don't think.
It's playing already.
It's playing, okay.
Honored to be with you today for your commencement from one of the finest universities in the world. Truth be told, I never graduated from college, and this is the closest I've ever gotten to a college graduation. Today, I want to tell you 3 stories from my life. That's it. No big deal. Just 3 stories. The first story is about connecting the dots. I dropped out of Reed College after the first 6 months, but then stayed around as a drop-in for another 18 months or so before I really quit. So why'd I drop out? It started before I was born. My biological mother was a young, unwed graduate student, and she decided to put me up for adoption, and that I should expect to live no longer than 3 to 6 months. My doctor advised me to go home and get my affairs in order, which is doctor's code for prepare to die. It means to try and tell your kids everything you thought you'd have the next 10 years to tell them in just a few months. It means to make sure everything is buttoned up so that it will be as easy as possible for your family. It means to say your goodbyes. I live with that diagnosis all day. This is life. Don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown out your own inner voice. And most important, have the courage to follow your heart and intuition. They somehow already know what you truly want to become. Everything else is secondary. When I was young, there was an amazing publication called the Whole Earth Catalog, which was one of the Bibles of my generation. It was created by a fellow named Stuart Brand, not far from here in Menlo Park, and he brought it to life with his poetic touch. This was in the late 60s, before personal computers and desktop publishing, so it was all made with typewriters, scissors, and Polaroid cameras. It was sort of like Google in paperback form 35 years before Google came along. It was idealistic, overflowing with neat tools and great notions. Stuart and his team put out several issues of the Whole Earth Catalog, and then, when it had run its course, they put out a final issue. It was the mid-1970s, and I was your age. On the back cover of their final issue was a photograph of an early morning country road, the kind you might find yourself hitchhiking on if you were so adventurous. Beneath it were the words, "Stay hungry, stay foolish." It was their farewell message as they signed off. Stay hungry, stay foolish. And I have always wished that for myself. And now, as you graduate to begin anew, I wish that for you. Stay hungry, stay foolish. Thank you all very much.
Thank you. That's okay. So that's the example of giving. Oh. Okay. Thank you very much. That's all my talk. I think it might beneficial for you to part of your practice, and I also strongly believe that not only being a great surgeon, you have to practice in your operating theater or you have to see your patient, but also you have to have all soft skill that you would be able to empowering your skill or your practice to deliver to not only your patient, but all the society. Thank you very much, MESDA. Thank you.
Thank you, Professor Sutep. That's a really informative and very inspiring talk. So I think, as you showed the Steve Jobs speech, that's also my favorite speech also. Stay hungry, stay foolish. That is very inspiring quote from Jobs. It seems like the message of the speaker sent it directly to the heart of the audience, I think, for the Jobs speech. So thank you so much. Dr. Voraboot, do you have any comments or do you want to add something? Because as a surgeon and as a singer, I think you have a very useful tip for like singing in the front of the stage and you have, I think you also singing very well, and you I think you have a secret to deal with the feeling when you are in front of the many people, right? Do you want to share us a little bit?
Yeah, first of all, I would like to thank you and congratulate Professor Sutep for an excellent lecture. And I think this topic is very challenging. Even me, I think I'm not a great public speaker, Dr. Siripong, but the way how I express to the audience, the way how I interact with them is something like I just imagine that they are my friends, something like that. They are my family, and then the way how to talk to them, the way how to react to them, it's from the bottom of my heart. So it's not like, you know, it's not like a react, like try to act this, act that. It's not yourself. I try to be myself as much as possible, and then I try to communicate with them as they are my friends and family. And then I think you have to be brave. You have to be brave first, and then you don't have to be scared if you do anything wrong, or if you do anything like clumsy during your speech, and especially English. I think it's okay to speak not like so fluent, but I think you just go slow and then try to make you confident and more comfortable when you stand on the stage and then talk to other people. And don't think, I think the most difficult barrier is you think you are thinking that other people try to catching something in catching mistake from you. So that's we will minimize your confidence level, and then that's I think catastrophic gonna happen during the talk. So just be yourself on the stage, and then look at everybody like they are friends, family. Mistake is okay because you're not a great public speaker. That's my view, and but I would like to ask Professor Suthep, because you are not Steve Jobs, right? So very difficult to draw attention from other people to focus on you. You have any tips and tricks that you can let other people focus on you? Yeah, please.
Yeah, thank you very much. Yes, we're not like Steve Jobs. We would love to be, but anyway, that's also part of the practice that we need to do. If you have a very good response or the attractive to the audience already, that might not be too difficult. So then you can deliver what you want. But as you mentioned, as surgeons, as a young surgeons or practicing surgeons, how you can draw interest from the audience. I think number one, the topics must be very attractive. Then also you have to study very clearly in that topics in detail, and you have to be like the most expert, and also you are the you have vast knowledge. So this also I give this practice to all my junior, that you have, if you get an opportunity to speak out in front of people, you have to do it very well. So then you have to research, you have to practice. Finally, you have to get the attention from the audience. Like you said, Voraboot, on that stage, you have to catch the audience, and then you try to get like you and they are in the same table that we are discussing. Have yourself comfortable. But very important is that the message that you get to the audience is very important. They will remember you from the messages that you get to them. For example, for Steve Jobs speech in the comments in 2005, you can see that yes, we remember Steve Jobs, we know him well, but the speech is still in our mind, keep for last very long for that part. So I think this also all the factors that we need to put together, and practice will help. Thank you very much, Voraboot.
Thank you very much for a great tips, Professor Suthep. I think all the trainees will learn a lot from you. And Dr. Siripong, I would like to move on to the next topic, okay? Because we are a little behind the schedule a little bit.
Yeah.
So thank you very much, Professor Suthep. ครับ ขอบคุณครับ
So I think,
and then the next topic is very interesting. To be honest with you, personally, I have been waiting to listen to this talk for a long time. Okay, and the topic gonna be the how to become a skillful MS surgeon, the secret of Yoda. And if you've seen the Star Wars movie, I think you must know the Master Yoda. The Master Yoda, he's the great warrior, and he's not only great in fighting, and he also great in teaching a young Jedi to become a great Jedi. If you ask me who is the Master Jedi, Master Yoda in our MAS field, I would like to say he's the one. Ladies and gentlemen, allow me to introduce you Professor Kaz Zunori Kasama. Professor Kazunori Kasama. Now he's currently a director of Weight Loss and Metabolic Surgery Center, Yotsuya Medical Cube in Japan. He's currently a president of IPSO APC, immediate past president of APMBSS, and executive board of IPSO. I think, in my view, he is one of the best MAS surgeon in this era. So it's such a great opportunity for us to learn from the true Yoda. Okay, ladies and gentlemen, please welcome Professor Kazunori Kasama.
Thank you, Minnie.
Thank you.
And I also appreciate Dr. Siripong and Professor Pitong for giving me opportunity to talk about how to be a MIS surgeon, skillful MIS surgeon. Actually, that last time, in this morning, Dr. Pitong said we have to prepare a new normal. So this is the beauty of new normal. I can have a lecture with my puppy. And one of the problem is that she tried to lick my face during my lecture. And anyway, I'd like to share my slide.
It's on screen
Can you see
now.
my slide?
Yeah, it's on screen.
Beautiful. Yes.
Oh, that's
It's
good.
Yeah.
So the Mini gave me a title of The Secret of Yoda. And actually that I'm a movie freak. So that I'm very glad to accept this title. And I'll be geeking out about the technique and some movies for this 30 minutes. And actually that I'm a little bit embarrassing because, the Sutep just talk about a great presentation. So I try to be a good presenter here. This is my COI. So first question is, why a MIS surgeon must be skillful? This is the answer. So 2013, the Michigan Bariatric Group published very nice paper in New England Journal of Medicine. And 20 bariatric surgeons in Michigan State submitted the video anonymously, and they use a skill scoring system and compare the results of top and bottom quartile. This is how they rate the skill. The 0.1 is the chief resident level, and the 0.5 is a master bariatric surgeon level, using a gentleness, time and motion, flow of operation, instrumental handling, and the teeth exposure. You may see the video of their own.
Throughout each step, the field is clearly visible.
This is a video of high-rated surgeon.
When setting up the bowel anastomosis or connection, the bowel limbs are aligned in such a way as to make the operation appear easy.
They made jejunostomy with a stapler. And the suture enclosure.
Even during freehand suturing, which is a difficult task, the needle is maintained in the correct position, and the bites are precise and accurate.
They say that the freehand suturing is a little bit
One
difficult,
stitch flows seamlessly to the next.
but this surgeon performs.
With regard to technical proficiency, there is little to criticize in this video.
They say that this is little to criticize on these videos. This is a low-rated surgeon video. This is more.
Here the bowel is
watch.
not well aligned with the stapler, making it difficult to place into the lumen of the bowel.
As you notice, the surgical field.
Furthermore, visualization of the operative field is impaired during much of the procedure, due in part, at least, to inadequate retraction or poor tissue alignment. Finally, instrument handling appears awkward, especially during suturing of the bowel.
They say that the suturing of the bowel is not very good.
There are several missteps during this part.
And you can see the results of surgery. And the lower rated surgeon has much higher complication ratio, reoperation ratio, and the readmission ratio. Regarding surgical mortality, is 5 times higher in low-rated surgeon. So that you can know that the skills directly related to the patient's safety. So I'd like to talk about the baseball. You know that this is a superstar of the baseball, Ichiro. The baseball consists of hits, run, catch, and throw. It's the same in MIS surgery. The surgery consists of cut with stapler, lymph node dissection, and the ligation, and suture. But many have been trying to avoid the suturing in laparoscopic surgery, like you saw in a low-rated surgeon. They use some instrument, not hand suturing. But I have a question. Can surgeons who cannot suture perform the open surgery? Definitely not. So famous surgeon, Johann Mikrit said, I can recognize a good surgeon, not by how he cut, but how he shoots. So suturing is indispensable, even in MIS surgery. So in the land of laparoscopic surgery, last undeveloped lesion is suturing. So the mentor always says that the stick to basic. So that I would like to say, back to the suture. So I would like to talk about the genius, and you know many of them here in the screen. So I have a very nice opportunity about training with Muay Thai genius Senchai. The Sutep gave me an opportunity of the Muay Thai training, personal training with Senchai. Yeah, actually, he's a genius. I was so surprised by his technique. But this time, I'd like to talk about Master Yoda for bariatric surgeons. So Master Yoda for bariatric surgeon is this guy, Dr. Kevin Higa. We call him Master Higa. Actually, he has a huge influence to the worldwide bariatric surgeon, like Nimeri and the Kisburn and every part of the world. He has his followers, like me. Yeah, he has true Jedi Master. And 18 years ago, I went to Fresno to to see his surgery. And his surgery was like dancing, and he performs as a magician. And at that time, I said to him, I am not a genius like you. I don't think I can make it. But he told me, no, Kazu, it's not a matter of talent. It is a matter of practice. So after coming back to Japan, I bought my own training box and using very old TV. And I put some sticker in Chinese character. Some of you can notice that that means the fighting spirit. And then I try to suture every day, every night, and try to suture everything. Probably I have a training at least 3 hours a day at that time. And I still have a little bit of training in my center. And I try to suture everything. But I failed to suture the mouth of my wife. Even Master Higa couldn't do that. And because of that training, I could have many overseas live surgery, 37 times. And this is the biggest experience in Japanese laparoscopic surgeon regarding overseas live surgery. But you can see that this Canada and the United States, of course, I don't have a license of United States, but Michel Garnier asked me a live surgery in New York, and that was the first live transmission surgery from Japan to the United States. So I did the surgery from Tokyo, and then the audience saw in New York. But the distance is more than 10,000 kilometers, and time difference is 14 hours. So everybody said it's impossible, but I tried to erase the in of the impossible and make it possible. So this is a photo at the Montreal. If so, I also did live surgery from Tokyo to Montreal, Canada. So my hero Ichiro said that locking up the little feet is the only way to reach someplace extraordinary. Another secret is know the theory. So there's many principles of laparoscopic surgery. To be a master, you have to know that principles, like a position, patient position, access port, and also we have to use many instruments so that we have to know about instrument and the safe usage of device like hues of stages and the sensors cost of ELSA. And the coaxial setting is very important. I think that the port placement is very important and the first step of the MIS surgery. So this is a coaxial setting, especially for your training, it is the best setting, and target angle is also very important. So coaxial setting is important because we usually eat a dinner like this, never eat a dinner like this. So that the coaxis is very usual. But this is a post-site placement of my gastric bypass based on the coaxial theory. Now, what do you think about the disadvantages of laparoscopic surgery? Some said loss of tactile sensation, but I think so. I don't think so. But the limitation of the angle of instrument is the biggest disadvantages of laparoscopic surgery. When you do open surgery, dissection in this part is very easy, but how about this? It's very easy because you can turn your position. But laparoscopic surgery, the part is very easy, but how about this? This is a little bit dangerous. So at that time, you cannot change your position, but you can move the ground. This is so we call the move the ground theory. This is a very important theory in the MIS surgery. And also when I use needle suturing, I always think of the angle of needle. And also the position of needle is very important. And sometimes you need to grasp a needle like this in a very special situation. So I would like to show my jejunostomy in the short videos. I hope this the image is clear. The important thing is to keep good surgical view. They ask assistant to hold the small intestine and they keep a nice view. And don't do it rush. Don't rush to suture. Just do it carefully. And grasp a needle in one action, and then put the needle. I don't want to do the same thing twice or 3 times, so that the action the doing in one action is very important. And the suture and drive a needle carefully and pull out. And then one more suture. You may notice that there is no stress on suturing. This is just like a usual open suture. Probably faster than open suturing. And then you can make a knot. Of course, and usually just take less than 2 minutes to close the entry hole. So important thing is not to try do it quick. Actually, that my surgery is a little bit quick, but I don't mean to do it quick. Just focus on not to do anything unnecessary. And also important thing is understand the anatomy. So you may feel something wrong. Yes, this is a patient with totally inverted organs. Then she asked me to do a bypass surgery. And I did a sleep DJB. You may feel something wrong with this video. Okay, this is a totally inverted status patient. So, but as I know about the anatomy, I did the same things, even in the inverted world. And another important thing is know the reason of failure. For example, there are the 3 most common mistakes in intercorporal knotting. One is long short tail and the loop not parallel and the lift and drift. The long short tail, something happened, especially for beginners. The beginners usually make short tail long. And then make bow tie. But if you know the reason, you can avoid this one. And another one is the parallel to the loop. The correct way to slow a loop is like this, to make a parallel to the driver. But sometimes the beginner make a non-parallel loop. And another one is the lift and drift. The lift means a little bit have a distance from the position. The horizontal distance is a lift, and the drift is and the horizontal is a drift. Vertical is a lift. So that away from the suturing position is making suturing difficult. So we have to know the failure, reason of the failure. And also we have to make unexpected expect. So that means to prepare the strategy for worst scenario. Yeah, this is a surgery my fellow was doing, and he encountered the bleeding. Of course, this patient is a BMI over 45 or 50, not easy to make a surgical field. And he tried to stop the bleeding with the instrument. And he tried sucking out and find the bleeding point. And again, he tried to stop by instrument. This is a very critical situation because the morbid obese patient, we cannot convert it to open. Even if we convert it to open, this position cannot seen. And he tried to sucking out again. But suction does not work for stop breathing. So that I thought it's impossible for him. So that, and then I use my hand to crush the breathing point. And then change the operator. And I try to minimize the bleeding. And they still have a bleeding, but it's reduced. So I put a gauze and then sucking and watch where is the bleeding point. Actually, the bleeding from this point is, for my fellow, he could not expect, but this is, I could expect this may happen during surgery. So that I have a plan if there is a bleeding here, so that I could manage well. So we have to keep calm because we are surgeon. Surgeon always has to stay calm. Like, you know, that in the Splash Mountain in the Tokyo Disneyland, everybody's screaming and shouting. But a surgeon like me always stay calm. So another important thing is deliberate practice. So deliberate means done consciously and intentionally. So deliberate practice is a special practice of with purposeful and systematic, and focused attention and need a specific goal. So of course, surgeon needs some little bit of talent, but talent is not enough. The practice is important, and we should know the practice is different between good and great. And the expert performance is hard work and requires repeated training. And the focus break into the manageable part, and the goal setting and the perseverance is the key. And the feedback in the moment, just like I did for the fellow, the feedback in the time of operation is very important. So this is the Professor Whitgrove. He performed the first laparoscopic gastric bypass in the world. And he said that many said practice makes perfect, but this is wrong. He told me that the perfect practice makes perfect. So the deliberate practice is very important. And of course, surgeons need to be properly trained. During their training, the surgeon needs advice from a senior figure or mentors. And the surgeon also learns skill by observing the role model, both positive, I want to be like that, and negative one. I definitely want to do it that way. So we have to have two sides of role model, bright side and dark side. And regarding the role model, we have to have an image training and have a mentor models. So I think the best advantages of laparoscopic surgery for surgeon is we can easily review our surgery, and we can easily review the mental surgery. I always bring the Kelvin Higa surgery in my iPhone and try to analyze and mimic his surgery. And the mimicking is cut off unnecessary things and try to make my surgery close to the Kelvin Higa surgery. And the drill until unconscious competence. You know that this is a hierarchy of competence, starts from unconscious incompetence, and then up to the conscious incompetence and the conscious competence. And finally, we can reach unconscious competence. You know this movie?
That's it. How did it feel to you? Let me think. Don't think. Feel.
Yes, this means unconscious impotence. Don't think, feel. So I'll show my video. I hope this is a very nice view. So this is how I hold the needle in one action. This is normal speed. And then I try to show you the slow motion. When I grasp my needle, I put the thread to make it round. And there's several ways to hold the needle. And this is slow motion again. When I hold the needle, then I put the stitches, not straight, but a little bit round. And this is a push and pull method in one hand. And you may notice I grasped it twice. This is 10 times slower. You may notice that I change the position of the needle. But this is a very quick action, so that this is unconscious competence. And another thing is love MIS surgery. I believe in the power of MIS surgery and prefer to do a MIS surgery. Even for my lovely puppy, she will have a laparoscopic spay surgery in next week. And we need to be prepared for the once in a lifetime. This is a video of laparoscopic fry procedures. And the reason why I say once in a lifetime is, of course, this is the first in Japan, and no other still performed. And this patient was my mother. She was suffering from chronic pain of pancreatitis, so that I performed the first laparoscopic fry procedure on her. But if I couldn't suture like this, nobody can perform, and we need to have an open surgery on her, and she may have some trouble after open surgery. I'd like to talk about three masters. I asked them that the Fat makes an excellent bariatric surgeon. The Master Lee said, this is a Wei Lee, talented in technique, and serious to your patient, and the focus in practice, and chance from God. He's a very smart person, and he concluded in only 4 sentences. And also I asked Master Higa, that he replied me, there are 3 qualities to lead to excellence in bariatric surgery: curiosity, and humility, and integrity. And the curiosity is an essential drive to find the answer. And also I was very curious of metabolic surgery, so that curiosity drove me to this position. And the humility is also important. Understand that we don't understand anything. Understand that we cannot do something. And honesty and the morality is very important. This is what Master Yoda said. And finally, I asked Michel Garnier. He replied that 10,000 hours of practice, 10,000 articles read, 10,000 patients operated, but mostly an incredible passion about what you do, and the attention to details and the continuous pursuit of excellence. So this is my favorite player. He is only one person who joined the All-Star game of baseball and American football. He's Bo Jackson. He said the reason why he can reach such a position is set your goal high and don't stop until you get there. And I would like to say to the young surgeons here, don't be afraid of challenge. Challenge is fun. This is my photo. I'm not an expert surfer, but I love to challenge the wave in Bali. And I'm the black belt of Kyokushin Karate and the Muay Thai player. But recently, I started new martial arts, Brazilian Jiu-Jitsu. I started from white belt, but it's really fun to learn something new. So that, I would like to say, young surgeons here, to get out from your merry-go-rounds and go global. In Yotsuya Medical Cave, we have international clinical fellowship, already have many surgeons from many countries. Of course, we have 2 surgeons from Thailand. They are now one of the leading surgeons in their countries. But first, I'd like to say that the surgery has no border. I had a live surgery in Kashmir, India. Kashmir is a very, conflict place. We have to think of the border between Pakistan and India. But during surgery, I did a sleeve DJB, and Ajana from Thailand and the other surgeon from Oman and India voluntarily became my assistant. And I felt there was no border. So surgeons can respect each other upon their skill, knowledge, experience, attitude, and science, not by the position, nor by the institute they belong to. So to be a master of MIS surgery is a long and tough way. I think I'm still on the way. It's not an easy decision. Always alone. You have to practice by yourself. It's challenging, but I think it's very rewarding. Master Yoda said that if you enjoy training now, if you choose the quick and easy path as Vader did, you will become an agent of evil. So my answer to how to be a skillful MIS surgeon, the Master Lee said, do not pray for an easy life. Pray for the strength to endure a difficult one. We should know that a smooth sea never made a skilled mariner. Thank you so much. I would like to inform about my IFSO-APC Virtual Congress, 25th November. 2 more weeks to come. And at that time, my presidency will be handed over to the new president from China, CC1. So this will be my last work as a president of IFSO-APC. So I would like all of you to join and register. Of course, it's a free of charge, so that the visit IFSO-APC site and hear my president's address for the last time. Thank you very much.
Right. Thank you very much, Professor Kasama, for not only fun, but very fruitful lectures. I did really enjoy your lecture a lot. And where is your puppy now?
Puppy is with my my wife. She's gone.
Yeah, I think that all the attendees have learned a lot from you. You have been stressed that why MS a surgeon must be skillful because of patient safety, and then that's very important. And you also stress that suturing skill is very important if you want to become a great MS surgeon. And
Yes.
the way how to be good at suturing is practice. And again, it's not just only practice, perfect. Practice makes perfect, right? So if you want to become a great MS surgeon, you have to become a trainee in under the experienced expert. And then you have to keep doing practice a lot. And then anything happen intraoperatively, you have to be calm down, call for help, sit tight, and then everything goes well after that. Thank you very much for the great lectures. And any comments from Dr. Siripong? I think you have to open your microphone, Dr. Siripong.
Yeah, do you hear me right now?
Yeah, I hear you now. Yeah.
Yeah, I would say that it's very fun and very inspirational lecture. Yeah, I agree with Dr. Professor Kazuma that skill is directly related to the patient safety, right? I think practice until the suturing skill become our instinct. That is the best. Yep. I think. I like the way Professor Kazuma practiced the suturing. That is very inspirational. He showed us suturing everything, right? Except your wife mouth. That is very risky. That is very dangerous.
That's the most difficult task.
Yeah. Dr. Siripong, I have one question for you, Professor Kazama. What do you think about if someone they think that you have to be a great open surgeon before you become an MS surgeon? Is that true in your opinion?
No, yeah. I don't think so. I mean, the time is changing. When I became a surgeon 30 years ago, the open surgery is the majority of procedures. But now, the MIS surgery is a majority of procedures. And the MIS surgeon can do surgery even if converted to open. So that open surgery is sometimes very risky for patient and many complications than MIS surgery. So that I don't put my patient to open surgery. So MIS surgery is much better. So that I don't think it's needed to be an open surgery master before MIS master. MIS surgery has MIS principles. Open surgery has open surgery principles. So it's really different. But the doing inside is the same thing. If you are MIS expert, you can do open surgery, not like the expert of open surgery, but more than better than average of open surgeon. So that important thing is focus on MIS surgery and practice a lot for MIS surgery. Of course, we need a basic skill of suturing, I mean the suturing in open surgery or cutting of open surgery. But we don't need to focus on that. Better to focus on MIS surgery. This is a quite new generation.
All right. Thank you very much, Professor Kazunori Kazama, for your point of view and also your lectures. All right, Dr. Siripong, I think we better move on to the next topic,
please.
Right? Thank you, Professor Kazama. So, ขอบคุณครับ I look forward to seeing you again in Thailand very soon, Professor Kasama.
Hey, I hope so. I will do a Muay Thai training again.
Yeah, we'd love to see your action in Muay Thai and probably learn from you. Yeah. All right. Thank you very much.
Thank you.
Yeah.
Take care.
Thank you.
Bye.
All right. Allow me to moderate into next topic. Okay. I think the next topic is also very interesting. I think being a perfect surgeon is not only doing surgery. I think conducting the research is also important in order to get a new knowledge, to improve our knowledge, and then finally can contribute to the patient safety. So when you conduct the research, you need to get published right into the international journal. And I think many surgeons has been struggling with how to get published into the international journal. So I think today is very such a good opportunity to learn, to find out the secret from our expert. Ladies and gentlemen, allow me to introduce you the next speaker, Professor Voraboot. Professor Voraboot, he's currently a professor of surgery and consultant surgeon at the Division of General Surgery, Department of Surgery, Siriraj Hospital, Mahidol University. And he's not only a great colorectal surgeon, and also he is, I would say he's the truly treasure of our surgical society in terms of medical research. He has been contribute to our society a lot. He authored more than 30 books, chapters, and also more than 100 peer-reviewed scientific papers. His work has been cited in the medical literature over 1,800 times with a H index 24. So ladies and gentlemen, please welcome Professor Voraboot. He's gonna give a talk about how to write a good manuscript and also how to get it published. Professor Voraboot, please.
Thank you very much, Dr. Voraboot, for your kind introductions. Good morning, my dear friends. Let me share my screen. Okay. In the next 25 minutes also, I will talk about how to write a good manuscript and get published. Let me introduce myself to you a little bit more. I get the Thai board certified on 2004. And at that time, I get the very first of my publications in World General Surgery, which is the randomized control trial, which is my resident papers. And then I moved to study the Master of Science in UK. During that years, I need to write around 15,000 words for the master degree thesis. And then in the next 3 years, when I conduct PhD thesis in Nottingham, UK, I need to write another 50,000 word PhD thesis. And then when I come back to Thailand, I do over 60 major operations a year, plus anal operations over 100 cases a year. I tell myself that I aim to publish at least one paper a year. This is my goal. So first thing, I think to become a writer and you can communicate your colleague globally, not only do the good surgery, but also publish your work and let them learn together. And hopefully we can improve the surgical care of our patients. But in fact, during the last 17 years in my clinical work, I get over 100 papers published in this corpus. And at least I get at least one paper a year. I quite struggled that year, but that is still fine. some years I get over a dozens of the paper, include recently this year, almost 10 paper. Like Dr. Voraboot would say, once your colleague admire your work, you get citations, and I'm sure you have a big smile on your face. Not only the experience of the writer I'm going to tell you, I will tell you about the view of the editors, because if you know what the editor look for, it's very important thing as you as a writer, how to capture the attentions of the writer, how to get the attention from the reader as well. So far, I'm in the position of editor-in-chief from the World Journal of Gastrointestinal Surgeries and also the co-editor of Sila Medical Journal. I also the editorial board on the journal I list on the screen. And I also be an ad hoc reviewer for several important paper in the surgical literature like British Journal of Surgery. I will bring you about British Journal of Surgery because when I was the first time of the reviewer of the BJF, they sent me instruction for the reviewer. It's not a secret, but if you know what the reviewer look for, I think it's very helpful for the writer. In that letters, they say they look for the scientific reliables of your study. It means that they look for the methodologies. If you have the good methodologies, whatever the outcome is reliable. However, although the outcome is very good, but the methodology is not reliable, so it tends to be rejected. The quality of your work, is it original? Is it novel? You can fill the gap in knowledge. You have a big hand to grasp on that journals. Although if your paper have clinical importance to surgeries or any advance of science or surgical science, that's very interesting to the journals. In terms of the presentation, I will talk to you about how to write in the good presentation this way. And of course, not forget about ethical consideration. In terms of the presentations of your manuscript, although it's not said in this paper, but I think the titles, I think you have no second chance to impress the editor or the viewer. So give some big impression with the title as well. But they say in that letter, in the abstract, concise and contain only hard data. Soft data just leaves it out because you have only 200 or 250 words to advertise your work. For the introduction, it's succinct. Succinct means short but focused on what you're going to say. In the methodology part, you need to give it in detail. How it's enough for other people to replicate your work. For the result, concise with appropriate statistic analysis. Discussion relevant and conclusions is must reliable based on the data you present. You cannot over emphasize your work. You cannot conclude over what you have done. For the reference, it must be up to date, relevant, because the reviewer or the editor will check it randomly whether it's appropriate for that work. Although it's not check every reference, but they check it randomly. I'll also check it randomly as well. The seminal paper, for example, if you talk about rectal cancer surgery, TME, I'm sure you need to quote a paper from Bill Hill, for examples. For seminal paper, you need to quote. In terms of table and figures, you need to focus on the quality, the number of the paper, whether it's too much or too little. Okay, let's move from the type of manuscript. You have editorials, manuscript, systematics, review, and meta-analysis. If you want to conduct this kind of study, you need to know what is PRISMA. PRISMA is a checklist that is universal. If you want to conduct the meta-analysis, you need to follow PRISMA study. For the RCT, you need to register to the acknowledged organizations like a clinical trial.gov in Thailand. You can register to the Thai clinical trial as well. And you need to follow the consort principles to make sure that you report everything and you report it systematically. For randomized control trial like observational study, you use Strawberry. For myself, I also mentioned this. For examples, this study was conducted with accordance with Strawberry. So it makes the reviewer so that, okay, you have some principle to follow. And also you have care report and letter to editor. Here is the basic structures of the original manuscript, original research. You have titles, abstract, introductions, method, results, discussion. This is the way you read a paper. And in the central part, it's called main text. But when you write the manuscript, you not write it from start to the end, but you need to pick up method as the first writing, because whatever the result is, you never change the methodology you work, so you can write it beforehand. And then you can wait for the result and you can see what's going on. And it make you have some clue to write the introductions that bring the reader to the methodology and the result. And then a discussion part. For the abstract, actually, this is the thing you write later after you have the bigger and clearer view of your study and also the title page. Not mentions about the reference. I think now it's unacceptable to use the manual to fill the reference. I'm sure you need to use some software to like EndNote or reference manager to manage, to make sure that everything is perfect, to adjust the format or the correct of the reference you refer to. Let's start with the title page. In general, when you write the paper and you want to submit your manuscript to the editors, every journal requires the title page. The title page at the top you mentioned about the title of the articles. It's no rule of thumb, but try to keep it short but concise, let's say around 12 words. You need to write the name of the author, their affiliations, and the detail of corresponding author. You may write, this is an original manuscript, this is a case report, and have it been presented anywhere. Some journal is mandatory that you need to mention, is it presented previously? They may ask the short run titles. It should be less than 40 letters include space. Sometimes you need to put the word counts. In general, for a manuscript, for original manuscript, it should be less than 3,000 words. But for the review, maybe extend to 5,000 words. You may need to, how many figures? You have a color figures, black and white figure. It depends on the instruction to order, but you need to follow it carefully. But I think almost all the journal require that you need to state sort of funding or conflict of interest and in the first hand. Okay, let's talk about titles. This is I will give you the example of my paper. This is clear. The length of small bowel in Thai patients. So it's capture the attention of the reader if they're interested. What is the bowel length? What is our bowel length? What is our Thai people bowel length? It's short but meaningful. Another thing, you can put the title as a question. What are the risk factors of colonoscopic perforations? I ask the questions, but in the papers, I will answer the questions. So it gives the audience that you advertise your paper and they buy in. Okay, you can use another one, like impact of metabolic syndrome on the short-term outcome of colorectal cancer surgery. It can be positive impact, negative impact, or even no impact. So you make the reader curious. What is inside this paper? Make the editor, you capture the attention of the reader, reviewer, and also the editor. Sometimes I put a very, for me, it's horrible titles. I think it's too long. Comparative study of the characteristic of Meckel diverticulum, blah, blah, blah. And for me, it's too long. But it's my early experience that maybe it's not good enough. But I show you the several ways and you can choose what you like. And if you are the reader, what you like. Let's move for the abstract. We proceed to 200 and 250 words. Let me tell you that abstract is the condensed versions of full paper. You need to write, rewrite until flawless. We expect that the abstract must be 100% correct. There is no typo error. There is no typing of the number. That error is not correct. Sometimes I see one number in the abstract, but another number in the result in the full text. It makes the readers or the editors skeptical about the correctness of the whole paper. So you need to rewrite. We expect zero typo error in the abstract. And this is your window shopping. You're going to get into the shop by look at the window, but if you're not interested, you just walk bypass. The same as the editor and the review. You need to give them the clear background and objective. Method short, but normally you tell what is the inclusion-exclusion criteria and the outcome measurement. Again, result, hard data. What it means hard is main and key finding, and it's significant as well. Conclusion, again, based on your study. You cannot over-elaborate or over-emphasize your study, just based on your study. This is the major flaw of the authors. I see very often they conclude not based on their paper. You need also to provide the keyword. I recommend you search the medical subject heading. This is the online tool from the PubMed. This is the standard word, and it make it when you search the paper. If you put this mesh word, so you are likely to be searchable. So keyword is a way you get citation from the other as well. Okay, let's move to the main text. The first thing first, one paragraph, one key message. One paragraph, one key message. From the introduction, you should have at least 3 paragraphs with 3 messages. First paragraph, you tell what we know. For examples, rectal cancer is the third most common cancer in the world, and laparoscopic surgery has been safe to perform whatever. But we don't know that if the tumor is invade to the bony structures, can we do laparoscopic surgery? I give you some examples. And the third paragraph is the objective of this study. We want to evaluate the safety, feasibility of laparoscopic in composite prostatectomy with straectomy, for example. 3 paragraphs, 3 messages. And then when you move on to the methodologies, it's like you like to tell the story. What is your patient selections? What is the inclusion criteria, exclusion criteria? What is your hospital settings, the time of your studies, to make the reader have the same view of yours. And then if you have some interventions, you can give the detail of procedures, how to do random your patients, for examples. And then you move to the statistic analysis. What statistic you use? Actually, if you have the medical statistician help you, it's very easy and straightforward for the statistic part. But okay, we have 14 topics and so far we need 3 in the introductions and another 3 in the methodologies. Again, another 3 in the result. It's like telling story. When you read the result, how many patients you recruit, how many exclude, and comorbidities, age, state of the tumor. For example, this is all patient characteristic in 1 paragraph. You may shorten these descriptions by using tables. If you use it wisely, it's very helpful. And then you move on to the primary objective. For examples, for the composite prostatectomy with straectomy, minimally invasively, length of hospital stay, length of surgeries, but loss, percent of conversions, let's say short-term outcome. And then if you have the secondary objective or long-term outcome, you can put it later because the sequence short-term is happened before long-term. So if you present it in the timely manner. For the discussion in general, you can recap your main finding in the first paragraph. For example, this study demonstrated that laparoscopic minimal invasive surgery is safe and feasible in composite prostatectomy and straectomy because it decreases hospital stay, for example. And you can recap, not rewrite again, but you can recap in other words. So if you have the skill for rephrase, paraphrase is very good because you deliver the same message, but in the different wording. And then you will discuss what is there any evidence support? Is there new things? Someone can do it before, someone says it should not be done. So support orthodox evidence. Is there any implications? Is there any limitations? This is the session that the reviewer and the editor expect to see. No manuscript is 100% perfect, even in RCT, still have some limitation. When you write the limitation, you may suggest something that, for example, this is performed in the specialist tertiary centers, but maybe it cannot generalize because to exclude some diabetic patients, whatever. You may suggest the future study for the broader group of the samples. You may suggest that we can work it as a multi-center study, whatever you can say. And then again, conclude the key message based on what you have in your study. So I think this 14 topic sentence or this 14 paragraph is the fundamentals for every manuscript. Okay, in details about introductions, what we know, limit, use reference widely, pertinent, classic. You cannot get 30 reference in the introduction. Sometimes I can see some paper quote 30 reference in the introduction is not acceptable by the high standard of the journals. What we don't know, what we need to find, you need to, sometimes you have primary objective, secondary objective, and you need, sometimes you want to have subgroup analysis, mention it earlier, because it makes the reader some hints that you're going to do it as planned. Because if you do it after study, we call ad hoc. Ad hoc analysis is not the solid data. Ad hoc analysis is just the exploratory, and you cannot focus on ad hoc analysis or the conclusions because it's not your primary objective. What you need to focus is primary objective, and you use the ad hoc analysis as an explore study in the future. Material method, like I tell you before, you can writing why you do some experience. Detail enough for others to repeat. But some procedure like Western blot, PCR, or for me, I do enhanced recovery after surgery. I mentioned that the detail of ERAS program in Sri Lanka Hospital was published in that paper. But you can say briefly what we do, maybe just a couple of sentences, that's fine. Mention every time that this study was approved by the ethical committees, the written informed consent was obtained from every patient. This is standard. For who familiar with PICO, you can use the PICO font writing. P is populations, I is the intervention, C comparison, or objective. You can use the same one, PICO, in the methodology. Statistics is used widely, sometimes as a reader, as a reviewer. It's very easy to spot whether the writer, the author understand the statistic analysis. If the SD is 2SD is larger from the mean and give some negative data, negative like 2 plus or minus 5, for example, I say this is the deviate is not normal distribution, you need to report as the median and least. It's easy to spot by the experienced leader. And they say, okay, you don't know how to represent. It's probably you don't know how to use the proper software to analyze. You need to use like a man-Whitney UTS rather than you need to use a chi-square, for example. Result, main findings, tell stories, use table figure wisely, don't duplicate the text and the figures, avoid lengthy analysis, and don't speculate, elaborate, or discuss any result in the result part. You cannot write, interestingly, there is significant difference in blah, blah, blah in the result. Remove this emotional word, interestingly, unsurprisingly, because you just report the fact. Don't speculate and don't discuss anything in the result. Leave the result as a result. Okay, like say, patient characteristic, first objective, secondary objective. Every time you present with percent, you need to give the absolute number. This is a rule. Give the absolute number with percent. In the discussion part, recap. Normally when you recap, you answer the questions, but don't repeat the result. Actually, it's repeat the result, but you paraphrase it. Related to exist knowledge, but if it's a gap in knowledge, your paper have the high possibility to get published because you fill the gap in knowledge. Clinical implications, limitation, justify conclusion. Let's move on to the reference. I may have only five minutes left. Okay, relevance, presents, highly selective, don't miss quote, and use the correct journal style. The last thing is very easy because you use a note or reference manager to adjust. Relevant, present. If you expect who's going to read your papers, there is big name, quote them. For me, enhanced theory of surgery, I always quote the Henrik Kellett or Ole Lindqvist because their papers is the seminal paper you need to quote. Okay, key to complete manuscript. The hardest part is to get started. It's of course, you need to look at the process of writing of the enjoyable, challenge, and fun. You need to have some interrupt. I cannot write the manuscript in the theater during the case changing. I need to at least have a full hours of interrupt. If you get 2 or 3 hours, that even better. I can write the method maybe in some introduction part as you collect the data. So you have something on your note. Write something is better than write nothing. For me, I prepare ghost tables to fill the result because it's easy when you communicate to your medical statistician. Okay, I want to know the comparison about age, sex, observed stay, for example. They can fill up the gap and the table view. Again, 1 paragraph, 1 key message. And then when you get the manuscript of yours, you want to submit it, of course. Send the manuscript to your colleague. We expect that every author have responsibility because they are the co-author. They need to read. You need to have the responsibility. Give the feedback critically to the writer. Spell check, abbreviations, flow of the language. For the corresponding author, you need to follow the instruction for author. Obviously, the editorial officer can reject if not comply with the journal style. Copyright transfer, conflict of interest form. Another thing that no one mentioned is cover letter. Cover letter is another thing because titles, when you go to the movie theaters, you see the titles and then you see the cover poster and then you see the trailer. But if the cover page is not interesting you see the title and then you see it's a very boring cover page. Sometimes you just reject it. Okay, some trick for the cover letter because it's another way to advertise I rarely seen Thai author make the cover letter attractive. In the cover letter, of course, you tell what is the type of the articles. You need to summarize and show the importance of your paper, why it should be published, why this paper should be published. I will tell you, I give you one example of my coverage. Okay, I tell the type, this is comprised with your journals, and we say to the base of our knowledge, this study is the first study compare something smaller, we look for this, and our paper provide evidence of something, and this our finding would encourage surgeons and their team or leader to implement of ERAS in emergency surgery, for example. This I put this in the cover letters. This is the chance of your to advertise your paper to the editors. If the editors buy in, they will send your paper to the reviewer. If the paper is they not buy in, they just reject by the editor office. Once you get review and you get some feedback from the reviewer, rule of thumb, when you get the feedback from the reviewer, you get a big chance to be published, but you need to answer that questions. And you need to thank the reviewer and think positive. Read all comment and suggest and respond all comment wisely. Each change you need to highlight and mentions back to the point by point clarifications when you resubmit your papers. You can strengthen your response with reference, of course. Sometimes the reviewer misunderstands, but you need to explain it politely. I will give you the example. And you can get help from the other authors that how we can change, how we can respond to the author. Here is the examples. You can see I will answer the question in one by one. I also mentioned, thank you for your kind notice of typo error. We meant to use this word, blah, blah, blah. We do agree with you that this is the best way. However, I make some argument. However, this is our limitation, whatever. For your kind suggestion, sometimes we write this, but the reviewer misunderstand. But you say it's not their fault. Maybe it's our fault. Maybe we did not state blah, blah, blah clearly. So you look very humble when they read your response. Oh, Voraboot, you are very good. You're very humble. You try to answer our questions. You adjust your manuscript based on my suggestion. You respond appropriately. I'm very happy with you. Okay, no further comment. Accept. That's it. But the journey is not smooth as you will expect. For example, I give you the number 70 of my manuscript, which is emergency colorectal surgery using ERAS program. I submit. I aim high. Another way, because disease colorectal is the highest journals in the field of colopathology. When I submit, they say the sample is too small. You compare two groups as orange and apples. They reject. That's fine. Okay. I aim another one. Disease colorectal, the number 2 in this field. Okay. First reviewer, it's good. It should be published. However, the second reviewer, again, small study, only cancer, not diverticulitis, for example. So you need the third reviewer, and the third reviewer can be editor. They say, okay, it's not good enough, reject. When you get reject, you need you be around like 1 minute for grieving, but you need to go on. If you put your manuscript in the drawer in your computer, it never get published. Third, journals, editors say, oh, it's not novel. It was rejected by the editor. It's not get any review. Okay, because maybe it's not good enough for them, and you can do nothing if the editor reject you. Okay, I move on to the third one. You can see I aim high, and then I slightly aim a little bit lower, but still have a big impact. And then this paper, Journal of Visceral Surgery. This is official journal from France Association of GI Surgery. They say interesting. Some minor revise and get accepted. So rejections is very common. Don't feel guilty, but take the comment of the reviewer to improve your paper. That is the key. Again, reviewer look for reliable method, novel origins, gap in knowledge, scientific sound, close to zero typing errors, readable writing. My mother tongue is not English, so I am like you that I just read English, write English as a readable, although it's not excellent, but readable. But good style. Good style is mean, like I say, one paragraph, one message, and then you bring the reader throughout the paper. Okay, good style, learn from reading, well writing articles, write it as a habit, learn from editor change. When some you typing earlier, there's some red line behind, check spell, check grammar. Okay, take home message, nothing impossible is nothing for surgeons, for me, for you, and practice every day. I'm a surgeon like you, so you can get published. Whatever you do, just do it, because if you don't do, you don't get published. And I'm very thankful to Professor Nalonglet Akayamani and Professor Winchai Rachata Mukhayanan to guide me for the very first research I ever did in my life, RCT, in the effective of pre-incisional bupivacaine injections on post-operative pain after appendectomy. Simple but solid methodology get published easily. And also, I'm very thankful to my family to support me to enjoy the surgeon life and like the life. Thank you very much for your kind attention.
Thank you very much.
Back to you.
Yes. Thank you very much, Professor Voraboot, for a great lecture, and I think it's very inspiring to all the trainees. And you have been stressed that tips and tricks how to write a good manuscript, and also you have been getting into the detail part of the manuscript that honestly I've never experienced before. And I've learned a lot from you, and I'm sure that other participants as well. Are there any comments? Dr. Siripong ครับ มีไหมครับ
I think that's a very useful and very informative lecture for I think as a real life methodology to get your research published. Thank you so much. I think this is very.
Do we have any questions from the floor? Siripong, do you have any questions from the audience?
Not yet.
No. If not, but I have one question for you, Professor Voraboot. Because I think English is not the primary language in Thailand, and I think one of the most barrier of conducting the research is the grammar in English writing. So it is necessary, in your opinion, is it necessary to use like English collector, or you can do it by yourself to be accepted in the really good journal?
Okay. For me, I never use the professional English correctors. In terms of grammar, you learn by your experience, but in one sentence, you need to have the subjects, verb, and object. This is the main key for the complete sentence. And you learn from the automatic check by you use the Word document. And if you need to use the professional English corrector, as you say, you not just to send the paper and then send back and you submit. No, you need to learn how they change. You need to ask for track change and you learn from them, because this is a learning process. Everyone can do mistake. I still have mistake during writing. Sometimes I get your English is not sufficient. Even I get many papers because the standard of writing, some is set very high, some is very low. But whatever you choose, the way you go forward, you need to learn and learn from your mistakes so you don't get the same mistake again.
And regarding the journal selection, how do we know our paper is suitable to this journal? I mean, or do you recommend that we have to aim high in all?
First thing, you need to check the aim, and you need to read the session aim and the scope of these papers. And then you just see some paper from me as a colorectal surgeon, International Journal of Colorectal Disease, they tend to accept systematic review and meta-analysis. For example, disease colorectums rarely accept visible study. They are the basics papers, but some paper they keen to accept the fundamental or ex vivo study, for example, cadaveric study. So you need to know the nature by look at what they publish. And if they have the same paper published recently, maybe sometimes when in the cover letter, sometimes I mentioned this, inspired by paper A in your papers. Mm-hmm. I read this paper, this published paper in your interesting, and then I submit. So you need to persuade the editor that you have some insight, your knowledge, interesting. I'm a big fan of your journal, for example. And then it's in the same scope. And then for me, I will aim high 1 or 2 level before. Because sometimes it's reject, but okay, you aim high, sometimes it's fluke. To be accepted, that's fine. If not, you learn from their comment. Because the high impact journals, once they reject you, they usually give the nice feedback, nice comments. What is mean nice is very useful for you to improve your paper.
All right.
That's the way I select.
Thank you very much, Professor Voraboot. You got your professor just at the age of 40, very young.
And I'm sure everyone who younger than me, this you can achieve the same academic positions. If you are academic surgeon,
Yeah. After this talk, we are trying to follow your footsteps, Professor Voraboot, and then we hopefully one day we can get a professor like you. Thank you very much for your great talk and your inspiration. All right.พี่ป้อมครับ What else you have?
Yeah, perhaps we can move to the next session. So I would like to turn it to our next moderator, which be Dr. Dishar, right? And Dr. Voraboot. สวัสดีครับ So are you ready for the next session?
Yeah, I'm ready because I'm gonna, continue doing the moderator into the second section in the morning, and I'm gonna moderate this section with my beloved young attendings, Dr. Nisha.
Hello. Hi.
Nisha, are you there? Here?
Yeah, I'm here. Ready. And I'm very excited to listen to the next talk of Dr. Voraboot. Very interesting talk.
All right. Okay. In the morning section, we learn a lot how to become a great public speaker. We learn how to become a great MS surgeon, and we learn how to write a good manuscript and get published. And then in the second section this morning, we're gonna learn more challenging point. The first one is gonna be, I think this is very important for you guys. If you are planning to study abroad in any country who speak English, you must pay a really good attention to this talk because the tip that will be given by our speaker can help you, make you feel more comfortable, make you feel more confident, and also you can communicate with your future colleague properly and correctly in the future. So I would like to take this moment to introduce the next speaker. Dr. Voraboot. She's gonna give a talk about English for surgeons, how to make it correctly. Allow me to give you a little detail about the speaker. Dr. Voraboot, she graduated MD from Vanderbilt University School of Medicine, and then residency training from Cleveland Clinic, Ohio, United States, and clinical fellowship in Geisinger Medical Center, United States. So ladies and gentlemen, please welcome Dr. Voraboot.
Thank you so much for your kind introduction. I'm going to share my screen real quick here. Let me know if you can't see it.
Yes, go ahead, please.
All right, thank you so much. So I'm going to first give a brief outline of the presentation, which is going to be, the brief. I was asked to, give a brief background of my training and, any style points that can help boost your communication. Now, if you're a trainee with staff, for instance, or with patients in a clinical setting, and, any tips or tricks in a conference setting, such as doing a video presentation, for instance. So just a brief introduction about myself, just so you know who this random person is giving this talk. So, as Dr. Voraboot previously mentioned, I did most of my training in the United States, but even before then, I was fortunate enough in that my father worked in the Ministry of Foreign Affairs. So we were posted, abroad quite a few times during my childhood. In fact, I never spent any more than 3 consecutive years in Thailand at any given point in time. So I actually learned English when I was in Switzerland when I was 6. So it's not necessarily my mother tongue either. But it got to a point as to where, I think at some point English became better than my Thai. But, at the same time, I was fortunate enough to, receive my training in the United States. So I did, the last 2 years of high school in Thailand. And then I went for a bachelor's degree at Harvard College in molecular biology. I subsequently went to medical school at Vanderbilt in Nashville, Tennessee. That was 4 years of medical school. And then I did a surgical residency at the Cleveland Clinic in Ohio. And the last thing that I did was a minimally invasive surgery fellowship in bariatric and foregut surgery at Geisinger Medical Center in Danville, Pennsylvania. And here are my classmates, from Cleveland. And here are the guys, the supporting nurses and my co-fellow at Geisinger. So, this topic is really interesting. And, as a disclaimer, most of this is going to be about talking styles and, your presentation, how you conduct yourself. But I think the main thing, for those of us, including myself, who are not native speakers necessarily of the English language, is that, a lot of people that I see tend to gravitate and tend to focus a lot on grammar. And that I would say is in terms of doing your presentation is probably not the most important thing. I mean, I know that, when we learn English in primary school or whatnot, that would be the first thing. But in terms of communicating with other people, with other surgeons and with, the patients, if you're constantly worrying about whether or not you're using the right grammar, whether or not you're pronouncing things right, that will inhibit your confidence and your ability to make a good presentation and a good conversation. Okay, so I think the emphasis should be more on the right words for the right situation. And it's not necessarily just about the language, not about English itself, but about the style of your presentation. Okay, and what do I mean by that? So let me give you some examples, okay? And I think this will probably make things a little bit easier to understand. So first, let's imagine that you are a trainee and you're trying to talk to your staff, okay? So the questions that I would recommend that you ask yourself first is, who are you talking to? Okay, to whom are you talking? How well do you know this person? Have you worked with them before? Say you are an intern, for instance, and you are trying to call your, your staff who's covering at night, who's on call. That'll be a little bit different than if you were the chief resident calling the same person and who maybe have had several months or years of experience working with the person and know what kind of style that person wants. Okay, and then the next thing to consider is what important information you would like to know if you were the staff. right? Like a presentation to a surgeon is completely different from a presentation to an internist in medicine, right? So the kinds of information that you're going to emphasize is completely different. And what was your previous interaction with this person? Now, this is important mainly in, for instance, if you're trying to call someone in the middle of the night, it's now midnight, and you're trying to figure out what style they want and all of that. That can be extremely stressful, and that will inhibit your ability to make a good first impression or impression in talking to this person. So the best scenario, I think, in terms of a good presentation to staff is to first establish the ground rules. So if for instance, that hey, Dr. Voraboot is on call tonight, and I know, so I call them up maybe at like 5 p.m. when it's not midnight and go, okay, so if you are on call tonight and I have to call you, would you like me to call you for every single thing that happens? Or would you like me to call you only for the emergencies? Or would you like me to tell you in the morning? What would you like? So I think the best case would be to have some kind of pre-established ground rules, especially if you haven't worked with that particular person before. Okay, and that will help with setting the stage for a good bilateral communication. So then comes the actual presentation style to staff. Okay, and you'll notice that nothing is really about the language of the presentation necessarily in this particular part, but it's more about the style. So I just kind of like made up these categories. So, the first would be the slow waltz, the next would be the concise, and then the short and sweet. So I am going to give you an example, okay, of each of these, and you can kind of appreciate the different styles and where you fall in them. I can tell you that, my personal preference is somewhere between the second and the third styles, not necessarily a huge fan of the first, but then it depends who you're talking to. Like, for instance, as a staff, who the resident I'm talking to and what kind of information I want from them. So let's take a quick look at this kind of consult. I'm going to give you a moment to absorb the information on the screen, but I am going to give an example, for instance, of the first style, which is the slow waltz. By the way, there's nothing wrong with any of these styles. It's just a matter of preference. And I'll tell you in a little bit why my own preference is in such a way, okay? So let's start with the first one, which is, the ones that you normally see, for instance, in, trainees at the beginning of their training. So I would probably call someone up and be like, Dr. Voraboot, I have a consult in the ICU. The person is a 63-year-old female who presented to the ED with 2 weeks of abdominal pain and several days of GI bleeding. They are now in the ICU. They were admitted last night for hypotension, and they're now intubated. The ICU team placed an NG tube and they lavaged the stomach with bright red blood. They already tried some endoscopy, but they couldn't see anything because there was a bunch of blood in the stomach. The patient has a past medical history of hypertension, COPD, atrial fibrillation on home Coumadin, and they had peptic ulcer disease in the past. Their home medications, as I mentioned, was Coumadin, and they came in initially with an INR of 2.4. They're currently on IV PPI, and they're on 4 different pressors. On my physical exam, the patient has a systolic blood pressure of 100/70. They're intubated with an FiO2 of 60% with a peak airway pressure of 40. My exam of the abdomen is that it is tense, it is not soft, and it's distended. Their labs show that they are acidotic with a pH of 6.9 and a lactate of 8.2. At this point, they've been massively resuscitated with 31 units of PRBCs, 6 units of platelets, and 7 of FFP. I think this person needs to go to the operating room because they have medically uncontrolled bleeding and concern for abdominal compartment syndrome. Okay, so take a moment and absorb that. That was a really long presentation. It was, complete. It gave all of the information on this slide. But as you can see, I had to listen and kind of wait until, the end of the presentation to kind of understand what was necessarily going on and get the entire picture of this patient. Again, there's nothing wrong with this style. It's, it gives all the complete information. It basically follows the normal format that you would follow with, like, the history of present illness, past medical history, past surgical history. It follows a very formatted and very, regulated style, if you will. Okay, now let's move on to the second way of presenting this same case, which is more concise. Okay, so I would probably pick up the phone and I'll be like, Dr. Voraboot, I have a consult for massive upper GI bleeding and abdominal compartment syndrome. This patient is 63 years old who was on home Coumadin for atrial fibrillation, who came in anticoagulated with an INR of 2.4. They are now in the ICU with ongoing active bleeding not controlled by endoscopy. They are intubated, sedated, with concern for abdominal compartment because the peak airway pressure is 40, and they are acidotic with a lactate of 8.2 and pH of 6.9. I think this person needs to go to the operating room. Okay, so the difference, if you will notice, is that, I have all the information right now in front of me. Okay, it basically gave the same information, but my first sentence was, this is a consult for XXX. And right at the very onset, especially if this is like in the middle of the night and you're like waking somebody up to tell them, they know exactly what to look for. Okay, they will ask you the questions like, they'll say, okay, like, what's the blood pressure right now? Like, what's the, like, what, vasopressors are they on? Like, you have all that information. I'm not suggesting you don't have it. You should be prepared for your presentation, but, you are giving the relevant information all at once, so that it's in a very short, succinct presentation style, okay? The third style is when you're a little bit more senior. Perhaps if you are a chief resident or, somebody who is, about to graduate perhaps, or if you've already worked with that particular staff for, a significant period of time and they know who you are and they trust your judgment. So in this presentation style, it would probably go something like, Dr. Voraboot, I have a patient in the ICU who's acidotic on pressors with abdominal compartment syndrome after massive GI bleeding and massive transfusion. The OR is available in 30 minutes. I have blood available in the OR, and I have prepared the patient as much as possible. When will you come? Okay, so they can ask all of the questions initially that, I was talking about, the patient history and all that stuff. But as you see, it was very short. It was very to the point. It was like, this person needs to go to the operating room. It'll be ready in 30 minutes. Are you going to be there? So that, as I said, it really depends on to whom you're talking. So you have to kind of know a little bit the style of that particular person and who you are. Okay, so if an intern were to tell me this, then I would probably have like a billion questions, and I would probably make them go back to the first kind of style at the beginning and go through every single thing, just to make sure that I understand what is going on. So, in the United States, when you are training for surgical residency, I would say that the style probably goes solidly in the concise style, in the second kind of presentation. This one, the short and sweet, it's more when you are, more senior, when you're graduating, and perhaps when you're asking another staff for help, that would probably be appropriate. This is at the beginning of your training, I would say. And honestly, the transition from, the different kinds of style is the ability of yourself to make a concise and brief judgment of what the patient's problem is. Okay, so that would be that part of talking to staff. Now, your style of talking to patients are a little bit different too. Like, you wouldn't use that, right, for talking to patients. So the tips that I have for talking to patients are, first, keep it simple. Okay, like, you do not need to use any technical terms when you're talking to patients. Having a picture, either drawing it or bringing it up on the internet, is extremely helpful. I would say tell them what you're going to tell them, and then tell the patient, and then tell them what you just told them. So you did this 3 times. First you set it up, Then you tell them, and then you tell them what you just told them. And I'll show you an example of this in a second. The best way to lose the patient is to not check for understanding. Like, do you understand? And they nod their head. Like, that is not a good indication of whether or not they understood what you said. Okay, so sometimes I would be like, okay, tell me what you understand about your disease, or tell me what you understand from what other people have told you. Okay, or do you know why you're here? That is a very open-ended question that allows you to evaluate what their baseline understanding is and how technical or how detailed you want to be in your explanation of the patient. Do not shy away from giving it straight. So if their loved one is, dying and there isn't much that you can do about it, do not shy away from just being straight with them. They will appreciate it. At least, some of it may be culture dependent in how you deliver these news, but, you have to be honest with the person in terms of what the chances are. Like, don't give anyone false hope or anything like that, which you're probably already doing. But in the English language, it's much easier to be completely straightforward with them. And then finally, the risks, benefits, and alternatives of whatever it is that you are offering to do for the person. So for instance, okay, like if a patient came to you with like gallstone pancreatitis and that is now resolved and they're in the clinic, I would probably show them a picture of the gallbladder and I would be like, okay, Mr. So-and-so, do you know why you're here? Or I understand that you're here for gallstone pancreatitis. Tell me what you understand about this condition. Okay, and then I would evaluate what their understanding is and whether or not it is correct. And then I would proceed with my own explanation. I'll probably go like, okay, let me tell you a little bit about this condition. You have something called gallstone pancreatitis, where you have stones in your gallbladder that fell down a little duct that leads from your gallbladder into the small bowel. When a stone gets in this duct, it can obstruct other things, leading to a condition called pancreatitis or inflammation of the pancreas. Right now, you don't have it because the pancreatitis is resolved. However, you have other stones in the gallbladder that can fall down the duct again and cause the same condition or worse. And then I would check for their understanding as to what they understand, and then I'll be like, okay, so the reason they referred you to me as a surgeon is to remove your gallbladder so that more stones cannot fall down into this duct, okay? And then, it's very easy from there if you preset what their fundamental baseline understanding is, and then you can kind of just take it from there, okay? You may have to tailor it a little bit based on the person's background, their educational status, okay? And what level of detail they want. Okay, and then I would probably talk about, laparoscopic versus open cholecystectomy, risk, benefits, and alternatives of the procedure. Okay, so that was talking to your colleagues and talking to the patient. In terms of at conferences, talks, and videos, we've already had several great talks about presentation styles, when giving a conference or a talk. And we're gonna have like more great talks about videos. So I'm gonna keep this brief, but the main pointers are not necessarily about the actual language itself. It's more about the style. So I would say number one, timing, be on time, especially if you're giving a talk with other people, like, set a timer, make sure you don't go over if possible, and then don't go under, just try to stay on time. Tell them what you're same format as the patients. Tell them what you're going to tell them, start with an outline, tell them and then tell them what you just told them. And then keep the presentation simple, okay? Like just have a few points on the slide, not too busy in terms of slide, and then know your audience. If you notice the presentations that were awesome today, they basically followed the same format as this. So I really have nothing much to add to this particular point. The brief side note on narrating videos, we should have been asked to talk specifically about is, in terms of like the presentation style to your staff, like we were talking about before, it's probably going to fall more into like the concise presentation that I demonstrated for you. So for instance, this is a video that was just presented at the American College of Surgeons Clinical Congress, the virtual forum. And, you know, it demonstrates, like, if you look at kind of like the HPI, the history of present illness of this, and, you know, talk about the present presentation of the patient, you'll find that this is very similar as to how I would present this case to the staff in a concise setting. You know, usage of visual indicators, like, you know, pointing at specific things, drawing specific anatomy, using of like labels and subtitles as you talk is extremely helpful. And I think the main thing is, you know, a lot of people have trouble about empty spaces in their presentation. Like, they would talk and then they would pause for a moment and the video would keep running and they don't really know what to say. That's okay. That's normal. That's a very normal thing. And sometimes it's really hard to figure out what to say in those particular situations. So what I would say is, in your presentation, especially on a video, speak clearly. Do not speak too slowly or too fast. And then when you are presenting, make a commentary, like imagine. Okay, like for instance, you know, if I have like a bunch of like videos and like a bunch of like shots, for instance, of like making the anterior gastrotomy, and I have nothing in particular to say about that, you know, instead of pausing and saying nothing at all in that particular instance, I would probably say something like, okay, you know, I'm setting up an anterior gastrotomy by retracting and lifting up so that I can set up a good field of view so that I don't back wall and hit the back wall of the stomach as I'm making this, or something to that effect. It's probably going to be more polished than that. But my point is, you know, there's always something and some little thing that you can comment on that will keep the video running and doesn't make any awkward pauses if you've already timed everything. The other thing is, you know, time it again before you write everything down, and then you know, practice it before you actually record it, so you only have to do it once. My final thoughts on this are, you know, I think it's extremely important that you strive for communication when you're using English and not perfection. As I said before, if you're like perseverating on whether or not the grammar is correct and whether or not, you know, someone is judging you on using the English language because it's not our mother tongue, that's going to inhibit your ability to talk. You're going to be nervous whether or not you intend it that way. And, you know, there is really no need for that. There are really great presentations out there without being perfect. And I think that's completely fine. It's important to organize your thoughts and follow the flow of logic, especially when you're presenting a patient to staff, because, you know, you have one shot at this, and if you make some kind of like rambling presentation and they couldn't figure out what you're talking about, and it's like in the middle of the night, they will get annoyed at you. So, you know, that is important. Pacing and intonation is really important, especially if you're nervous, you tend to talk faster. So, you know, be aware of that and just take your own pulse and maybe slow it down if you need to, okay? And then use the right language in the right setting. So that is connected to knowing who it is that you're speaking to. If you're speaking to a patient who maybe is not the most educated in the world, that's different from talking to a patient who is also a doctor at your facility, okay? So that, you know, is really important. So I conclude by saying that, you know, taking a quote from Steven Pinker, and that the language we use influences the way we think. And I think that's completely true. I'll be happy to take any questions.
Thank you, Dr. Voraboot, for your, I would say that was a really great lecture, and you know, you just gave us all the tips and tricks how to, you know, communicate with English native speakers. Yes, Dr. Nisha, do you have any comments?
Yeah, it is a very good lecture. You know, from this topic, like English for surgeon, it's like, it seems so very simple, and we didn't expect anything very insightful like this, and I'm very, very enjoying your lecture.
Thank you so much.
Any comments from the audience? Okay, if not, Bim, I was a fellow there in USA, and during my first 3 months training, I mean, in the beginning, I had lots of problem with, my colleagues, nurses, and the other residents, because our accent may be a little bit difficult for them to understand. You have any tips for us, to be better? I mean, communication with them.
Sure. And, I think you raised a great point in that, people have trouble understanding me sometimes too. And it's not necessarily anything that, you or anyone else does. I think the main thing is, as I was saying before, you have to know whom you're talking to. If you're talking to the nurses, it's extremely helpful, first of all, to introduce yourself if you've never met them before and be like, okay, I'm new here, and, this is, what I would like. Can you help me, get what it is that I'm trying to do? Like if you're trying to order some medication, you've never done that before, and, they're annoyed at you now because they've been asking you and paging you like 5 different times. It's not because you don't care about them, but it's that, maybe you don't know how to do it. And that happened to me when I was an intern. I literally was like, okay, I'm really sorry that I had made you wait for 30 minutes just to order some Zofran. I actually don't know how to do it. I'm going to sit right here with you as I do it. So most of the time, we think that people are judging us necessarily on like, what we say, and maybe they don't understand us because of the way we talk. But there can be a lot of other things that are underlying it. They can be, annoyed at you for a variety of reasons that has nothing to do with that. So I would say first eliminate all those other things that it could be. And then, in terms of like the accent, I think that will come with practice. It's just like surgery. As Master Yoda was saying, everything needs practice.
Thank you, Bim. And one thing, I think talking over the phone is sometimes very difficult as well. I mean, so in the beginning, I try to, when there, talk to them directly. I mean, not over the phone, because sometimes I couldn't understand what they try to, communicate with me. So, and also, the most difficult thing is when you are at the clinic, especially you are from the other country and not an English native speaker, and then you try to communicate with the patient. And then when the patient talk to us, right, and then talk to me, and then the accent is not very good, and then the pattern that I talk to the patient may be a little bit different from the native speaker, and then sometimes makes me feel like more uncomfortable and then not confident. So you have any tips and tricks that to be better communicate with the patient? Yeah.
So first of all, I'd like to say thank you so much for sharing that. That was very brave of you to say that. I think that is like a fundamental fear that we all have. I have the same fear of, talking to patients. Like, sometimes I don't know whether or not they understand what I'm saying. And maybe it's because I'm not explaining it properly. Maybe I'm not saying it in the right way. Maybe maybe they just don't understand what I'm saying. Ultimately, I think it's a work in progress. The most helpful thing I can think of in that particular situation is ask them what their understanding is first, right? Like, it's hard to explain to somebody something if they have zero understanding. Like, for instance, if they come to your clinic and you ask them, oh, what brings you here? And they're like, I don't know. Okay, that's a nightmare, right? Like, they don't even know why they're there. So then you start with zero. So that's a little bit different than if, okay, you're like, okay, so you know why you're here. And they're like, oh yeah, like I was in the ICU 3 months ago with gallstone pancreatitis, and now I need surgery. Okay, that's completely different. So then, I would say setting the ground rules really helps. And with your, specific thing about talking to people face to face instead of on the phone, I completely agree with that. If you are able to, that can be extremely helpful because facial expressions and intonations don't necessarily come across on the telephone.
Yeah. Thank you very much, Dr. Varnada, for all the comments and tips and tips to help us to be better and better to communicate with English people. Okay, so thank you so much for that. I hope you stay until the end of this session. Okay, and then thank you. ขอบคุณครับ So Dr. Nisha, what else do we have?
So the next topic this morning will be how to make your surgical video clips attractive. So ladies and gentlemen, I would like to introduce you our next speaker, Dr. Siripong Chewatanakornkul. She's currently the consultant of minimally invasive surgery unit of the Siraj Hospital of the Mahidol University. She had many experiences of the international video presentation, including the ACS Congress in San Francisco at the 2 years ago. Many of us must be wondered. Sometimes you do have like a very interesting case or the video, the surgery, but our video doesn't seem to like turn out great enough compared to the actual procedures. So Dr. Siripong will gonna show us how to make our video clips informative with educational values and attractive enough to draw some attention. So please welcome Dr. Siripong. Dr. Siripong, I cannot hear you.
Can you hear?
Yeah.
Thank you, Dr. Nisha, for your kind introduction, and also thank you, MESDA, for inviting me. And surgical video clip has been very popular education tool, and I think many surgical trainees and surgeons need to know how to make it attractive and how to make it like a wow. I have no financial relationships to disclose. Through this talk, I'm going to talk about 5 tips and tricks, some technique, and how to edit video from start to finish. And there are really 5 things you have got to do. The number 1, recording all your cases is great because you never know what something interesting might come up. Like this case, this is a malfunction of stapler. I recommend you to record the whole case. You never know what will be interesting until it's too late. And you can review the video, what is the problem. And tip number 2, get good images. You have got to start a good and high quality material, shoot the highest resolution that you have available at your institution. It's going to give you a better image. Make sure it's focused and the scope is held steady. Minimize foggy and smoke. You need to clean the lens. If tip get dirty, take it out and clean it. Section and clean the operative field. It's going to slow down your operation, but that doesn't matter. If just get a clean image, and it's also reduce surgical error. And tip number 3, choose a good topic, which is probably one of the most challenging part. Answer the question, who is your audience and what is the content? There are 3 general different kinds of video. One video may serve many purposes. There is educational videos, should a common topic. It should be really clear and easy to understand that make other surgeons who haven't done the operation before and focus on the important steps. If you have an unusual case or rare case, show the background on this case and how you can approach and what is your technique, or interesting complication and how you handle it. And there are new technique or technology. Is it unique or new or more superior? And spend a time to explaining the step of that new technique or technology. And then tip number 4. Some of these things that is very distracting is your transitions. You can have a fancy transition, but that is not right for a surgical video. Usually the best transition is a gradual dissolve from one to the next frame that you can see in the left video. And then sometimes we try to complete most of the procedure in 10 minutes with high speed payback, which is very distracting. I think the best is 2 times speed payback. The lower one is too slow and too fast. Tip number 5, you have to avoid, about the distracting, avoiding muffled audio and background music. There are excessive time spent on a specific task, such as suturing and suctioning, but I recommended you to eliminate all distractions. And tip number 5, keep it simple and clear. And you take a very simple thing and then outline anatomy very clear and highlight. So you might put an arrow or a circle, use a picture in picture and green screen. Use simple short word and your voiceover should be clear. I will show you how to edit the video from start to finish. And I personally use iMovie, which is a free software. There are many other similar programs out there that allow you to edit your clips. I also use Keynote and QuickTime Player for screen recording and Procreator for drawing picture. Start with tab to create a new movie. And first thing you need to do is to import the surgical video file in the iMovie library. I select all this raw file, then drag and drop in the bottom area which you actually produce the clip. Quickly remove unwanted section, such as out of the surgical field outside a patient body. Scoring in the timeline, tap the video clip. When you want to split the clip, split this clip into 2 sections and delete it out. I use Command B to split it. There are a lot of redundant action. You can speed up the clip, tap the speed icon and click the drop down 2 times faster. And I'm going to trim the clip again to select the key parts of the operation and get rid of this bad, boring section and redundant action. That is a little bit smoother and video move a little bit quicker. I split here and I delete And next, I'm going to show you how to highlight the anatomy. And select a frame on the timeline and tap Feed Frame in order to locate it. And then tap Full Screen. I take a screenshot of this frame by press Command Shift 3. I choose the other picture that I need to highlight. And then and this is a screenshot that I selected. I send the screenshots to the iPad. I use Procreate apps to draw the outline, anatomy, and paint it. I export this highlighted picture and send them back to my laptops. I use Keynote program to attach labels of the important structure. And then I take a screenshot and screen recording of these images, which as you can see in the photo, then drag and drop them in the timeline here. And this is an intraoperative ultrasound clip. I drag and drop that clip into timeline above the surgical video, and I tap split screen, choose its position as you need. And I would like to emphasize the anatomy. So I drag and drop Dr. Voraboot clip with a green background to timeline here. Then show the green screen. Adjust the size. So you still visualize the surgical background. I prepare the slide in order to make a complete presentation and take all screenshots of this slide. And then I bring them in the timeline. Should cause dissolve transition for the almost all of frame. And the next thing I'm going to do is adding ad tag and key operative step for my video to explain the operative step. And add the logo in a timeline. I shoot a picture in picture and adjust its size and position. To record your voice, tap the red button under the video and start record after countdown. And here is your voice. You can adjust and edit them too. And then tap to export your video file. And here is the complete surgical video clip. For scientific presentation, you should add some introduction and patient signs and symptoms, imaging, and diagnosis, thoracic site, give operative time, hospital stay, patient outcome, and having a conclusion too. This video show before and after making the clip, after I'm making it more attractive. I think the after one is easy to understand and very more interesting. And here is the important structure. You can add the size of the nodule, tumor. And to summarize what we talk about, 5 tips and tricks, there are record all cases, get a good images and choose a good topic, avoid distracting and keep it simple and clear. I think these tips and tricks might be helpful. Thank you.
Right, thank you very much, Dr. Kikampon, for beautiful lectures and video editing. Any comments from Dr. Nisha? Okay, she's not here now. Okay, I have one question for you. Because sometimes operation is very long, right? Very long, and then how would you select the part of the surgery? Because I believe that the long operation may be more difficult to do a video editing. So what is your recommendation?
First, I have to gather the idea that what is the operative step. I list that down, and maybe I try to cut only the key step that I list, because sometimes the operation take about over 10 hours, so it's hard to cut it. And the second thing that I do is I try to play the speed back to more than 10 times or 20, and then I scoring very fast to cut out the section frame that is maybe redundant action, or there are the out of the operative field. I think to think that maybe help me to cut the long period of that video.
All right, thank you, Dr. T. Kamphon, for the great answer. And then I think we learned a lot about how to make your video more attractive. I personally am not very good at editing the video, but I believe that after I listen to your talk today, I can be a better video editor. So thank you very much, Dr. T. Kamphon, for the excellent lectures. And I think it's time to move on to the last lecture in this morning. Dr. Nisha, you come back now.
Yeah, sorry for the connection error. Yeah, for the last.
Yeah, go ahead, please.
Okay, for the last topic of our morning session will be let's simplify your operation into an understandable illustration. So ladies and gentlemen, I would like to introduce you our next speaker, Dr. Shananya Horkiat. She is a general surgeon of the endoscopy surgery unit at Laparoscopic Hospital of Bangkok in Thailand. She also worked as the medical illustrator at the Siraj Medical Journal, or the SMJ, of our Faculty of Medicine, Siraj Hospital, Mahidol University. So some of us is not really familiar with drawing. You know, we're not good at art. Not everyone is good at art, but sometimes you have to draw our own illustration, because when we do our own manuscript or articles, or even when you write the operative note, sometimes we have to make our own illustration. So Dr. Shananya will gonna tell us how to make it easy. So please give us a warm welcome for Dr. Shananya, please.
Thank you. First of all, thank you, MESDA, for inviting me to share my experience here. Let me share my slide first. We're talking about taking the operative notes here. It is not time-taking procedure for us. We have little time, so I will introduce the equipment I use first, so you can pick up some to practice with me in these sections. The equipment of hand drawing, I use the single color ballpoint pen, and many times I have a bunch of pens in my pockets. So I have multiple ballpoint pens. Sometimes I shading with the highlights and color pencil. This is my daily practice. I usually use the black line drawing and then the color line to make it easier to recognize some organs. And sometimes if it is complicated, I use the pencil first before I draw the line. And the right picture show the markers I have in my big pocket. This is the actual pictures of me using in the ER. The left one is less than a minute. It's not time taking at all. And the second one is in the operative room after midnight operation. Let me have you take a look. This is less than a minute to take a lower eyelid lacellation. We have to make the landmark of the eye. You can recognize it is the left eye. And the wound is in the lower eyelid. And I make the eyelashes a little bit. That is complete. Sometimes I usually have this in my pocket too. That is too much for you all. And this is my electronic equipment. If you have to practice the presentation, sometimes you have to make it. The left one is the desktop in my working station at home. But if you are work anytime, anywhere, you can leave it to the iPad. The program I use when I use in the desktop, it is the Photoshop, the only Photoshop. And sometimes I use the Clip Studio Paint. And in the iPad, I use almost always Procreate. If I have the complicated illustration to do it quickly, I will sketch in the hand draw and take the picture in the iPad to color it. The fact that the operative note must be accurate first, not the artistic first. After accuracy, it must be understandable, and we don't have many times to leave it. So maybe we have to make it easier and simpler to less time consuming. The point is, in every view of surgery, you don't have to make the view of the surgery to be illustrated. Sometimes it is hard to understand the view. You can understand the angle of the endoscopic view in the video, but if it is illustrated, sometimes it is hard to recognize it quickly. So I recommend the view of the coronal view first, but some landmarks are necessary. And please do not draw too small. Beginning of the drawing, you have to understand the shape and form. If you want to draw something, you transfer it into a shape on the left side picture, and then you imagine it as forms in the right picture. For example, for a stomach, you have to shape it in the left side picture, and then you imagine it as a spherical, so you can paint it to be three-dimensional. Just as the liver, you have the liver shape on the left side, and then picture it. You have the pyramid, a spherical, and a cube, so you can paint it correctly. As in the colon is like a tube, so it is the cylindrical shape. Any skill here is not hard, but we have to practice more to let it more beautiful. So let's practice. I have two of them in the practice. One is the whole abdomen and the other is the colon. The whole abdomen, as you know, we have almost a cube shape abdomen, but the diaphragm on the right side is upper than the left side. And we have to extend the pelvic cavity as a triangular and at the lower one. Then we mark it with the easy to recognize landmark. This one is falciform ligament, which divide the triangular left lobe liver. And then we draw the right lobe liver, lining to the diaphragm. And then I curve it up at the gallbladder bed in the half right. Then we draw the stomach, which is begin with the esophagus. The esophagus is a cylindrical shape here, rather in the middle, and the stomach. The stomach is on the left side and extended across the midline to be the duodenum. And then we draw the colon. The fixing part of the colon is easy, the ascending and the descending part. We draw the line of the colon first. The splenic flexor is higher than the hepatic flexor, and then the redundant part of transverse and sigmoid colon to the rectum. Then we make it symbol of the line. The anterior organ will be drawn first, then the posterior after. That is easy, right? And a little bit of the shading if you have the markers. The other one is the colon. I will focus on the colon. The first one, we draw the line of the middle colon, mid of the colon, just as I draw in the whole abdomen. And then we make it a tube. Then we mark the illustrations. And then after marking the illustration, we outline the illustration. As you can see in this picture, this one, the illustration is not round, but the outline, I make it round. And then I identify the tinea coli, which is make it more prominent for the colon, and outline and coloring it. That's it. If it is the operation, I will give it a 2 shot. The first shot is the finding of the operation, and the second shot is the final point, the final operating procedure. This is the Hartmann procedure, which the produced in the sigmoid colon cancer. The left side, as you recognize, the distal colon is less than the proximal colon. The proximal colon is dilated a little bit, and it is simple mass. I use it as a cloud shape at the sigmoid colon. The color of the red, if you are hand draw, I recommend you to use the felt tip pen here. The 3 colors represent the artery, vein, and the nerves, which we also draw in some operation. The outline, I use the middle one, most of it. It is the felt tip pen, about 3 millimeters. Actually, in the operation, I do not draw with the pencil line. I just draw it directly like this. But sometimes, if we have complicated or we have to make it to the conference, I maybe start it with a sketch first, and then the line and shading, then color. Most of all, I draw it with coronal wheel, but this one has a drain to recognize in the far right. So I draw the skin in the cross section and make the drain across the skin to the out. This is for the X-ray conference a few days ago. It is the Meckel diverticulum. I draw it first and then outline it and coloring it. All the process is in one program. It is Procreated or anything else you are comfortable with. This picture takes me 7 minutes to complete. And yes, you all can do it. So this is, for example, of my illustration to demonstrate to you. And I think you are more comfortable to draw it with some simple procedure to more complicated one and practice fluently afterward. Thank you.
Thank you very much, Dr. Sanya, for the very, very beautiful presentation, actually, because your drawing was very beautiful. I have a question for the beginner who wants to draw our illustration to making our manuscript or in the operative notes, some kind of. We personally have problems of the scaling, when you do the very complex anatomy or drawing that has to sometimes it doesn't look like the proportion is wrong. So how do you fix this problem?
Proportion of the organs?
Yeah.
If for the beginner, you have to take picture and copy it. But as I recommended in the advanced one, I think the dimension of the anatomy is actually the knowledge one. If you know the normal anatomy to be like your stomach may be in the left side, but the antrum is in the middle, that can lead you how to draw it. But at first, I think copying is the fastest way to do it. If you want to do the illustration, you have to have an anatomy illustration first. And if you want to draw endoscopic view or laparoscopic view, you capture the picture and then you draw after that picture. That is the easier way.
Okay, thank you. Dr. Voraboot, do you have any question or comments?
Well, I have no comments because I have no talent on drawing anything. So, but again, because I have no talent, and also I believe that most of our trainee also don't have talent like Dr. Chananya. So do you have any tips for them? For example,
you want to draw,
if you want to draw
drawing, just begin right now.
Appendicitis. If you want to draw acute appendicitis, operative fighting, what is your recommendation? Which part they should start first? For example, you start with cecum, you start with appendix first directly, or something like that, and how to label the organ and label the finding.
I have a picture of appendicitis now. I will share it with you all.
Oh yeah, that would be great. Yeah, please.
This is my iPad. I have this appendicitis. I usually draw it with the cecum. You can see I place the cecum and the ascending colon first. And then I place the IC valve and then the appendix. When use it with color, I use with the red one and the gangrenous is the brownish one. But if it is the one's color pencil or pen, I will make the shadow, which represent inflammation. This is how I draw it.
Thank you, Chananya. I think the way you teach us, just start with cylindrical, for example, like the shape first, like cylindrical shape or circular or square or something like that. I think it does really help, to be a better illustrator. So yeah, thank you very much, Dr. Chananya, for your comments. And you look
Don't be afraid for starting the practice.
Yeah. Very beautiful today. Nice dress. I like it.
Thank you.
Chananya, she's my friend. Okay, a really close friend. And I learned a lot from her, how to draw pictures, but still her student. All right, any comments now, Nisha, before we're gonna end this session?
No, I don't have any. Okay.
All right, I think that's the end of the morning session upon the non-clinical skills that I think all of us learn a lot from the speakers, and definitely sure that we can bring all the knowledge and experience back and become a better and better surgeon in the future. I would like to take this opportunity to hand it over to the next moderator, which will be Dr. Piyanan and Dr. Tharathon for the section afternoon. Thank you very much for joining the morning section.
Thank you so much, Dr. Voraboot, to conduct a very beautiful session in the morning. I think as a surgeon, we need not only to build up our skill in surgical procedure, but in the soft skill also. We have a good opportunity to learn from the expert in the morning sessions. So right now we can upskill and reskill our soft skill apart from the surgery. Thank you so much for conduct us a very beautiful session in the morning, Dr. Voraboot. Thank you so much. So right now we turn up to our backbone session, how to be a good surgery by doing a good exposure. So Dr. Piyanan and Dr. Thanakorn will conduct you into this session.
Okay, next. Good afternoon, everyone. Okay, let's move to the welcome to clinical session. Now we are half of the way, and here my co-moderator, Dr. Tharathon.
Good afternoon, everyone. Good afternoon, พี่หลิง อาจารย์หลิง Piyanan. Welcome all of participants to our clinical session in this afternoon. Thank you, MESDA, Prince of Songkhla University and Sirirat Hospital Mahidol University to assign us for this great opportunity as the moderator of these interesting topics from our master surgeons. I am Dr. Tharathon Chewatanakornkul. I am now a clinical educator from Department of Surgery, Faculty of Medicine, Sirirat Hospital, Mahidol University. And Dr. Piling.
Okay, I'm co-moderator in this session. I'm a surgeon in Prince of Songkhla University. I'm Piyanan Wangkulankul. Okay, in this session, we are great honor to be your moderators to in the clinical session that Dr. Siripong said, the core bone core in the heart for the newbies, for the MS surgeon, for the starter. Dr. Tharathon, what is the topic of today, the highlight today in our session?
Okay, our session consists of one, critical view of safety, pitfall, and alternative strategies. And the second one is critical view of myobacterial orifice in inguinal hernia repair.
That's a topic, is a very common problem that in for the starter, right? And the LC is the first topic that we will discussing about it by Dr. Nanak. Okay, let me start to introduce him. Dr. Nanak Vibunkhwan, he is the lecturer from Prince of Songkhla University. He is the young rising star of the laparoscopic hepatosurgeon in Thailand. Please welcome Dr. Nanak.
Hello, everyone. First of all, I listened to all of the speakers today, and all of you remind me how to be not only the best academic surgeon, but also a wonderful role model in the front of public speaker and friendly English speaker as well. Those are my passion. In addition, one of my passions is to create and contribute to the bioduct injury prevention. So thank you for giving me this opportunity, this golden opportunity to share my idea. And I hope that my topic will transfer those ideas into your practice. And finally, if you have any question, please do not hesitate to discuss later after the session.
Let's start the video clip.
Good afternoon to all the audience. It is my honor to be here with you, and I would like to thank the organization committee and the course director, Professor Siripong and Professor Voraboot. So my first question today is, why the laparoscopic cholecystectomy and bioduct injury is still be a debated topic? And the second, what kind of ovulation that LC is actually be? Let's take a look at this video for an overview of the ovulation. So, in my point of view, there is a wide range of the difficulty in the laparoscopic cholecystectomy, from simple, straightforward to the most challenging one, which had a potential significant morbidity, or the bioduct injury, which in fact had a low incidence of 0.3%. However, cholecystectomy is the most common procedure performed laparoscopically nowadays. Let's say that there are 3,000 billion injuries for 1 million of patients underwent for cholecystectomy according to the 0.3%. Moreover, the surgery of benign disease, which turn out can change the entire life of the patient, or even increase chance of death. Lastly, it is not only the patient affected by those injuries, but a good surgeon may fall into a lawsuit or litigation. And I guarantee that there is no happiness in that. And with this information teach me that the cholecystectomy is not a simple procedure. However, I believe that the bioduct injury is preventable. This is the same belief for the group of the society. The suggests safe cholecystectomy task force, and also you may call the father of the critical view of safety. Back in 2018, I had a chance to meet the Professor Strasberg in Geneva, Switzerland. In the session, I introduced bioduct injuries. At that time, what I was realized that how he came up with the critical view of safety. The most important thing is that learning from the mistakes. He had a lot of experience for treating bioduct injury, and the critical view of safety was developed according to the cause of the injury. Now let me take you back to 1992, when laparoscopic cholecystectomy was just started. Professor Davidoff and his team reported a series explored the causes of bioduct injuries, and they found that the majority of cases caused by misidentification injury. In other words, the bioducts were mistaken to be the cystic ducts, so-called the classical injury. Therefore, to prevent the misidentification injury, the critical view of safety has been proposed by Professor Strasberg. Since then, the critical view of safety became the goal for surgeons doing laparoscopic cholecystectomy. Now, if we look at the current evidence, there is no sufficient data to recommend or define the best strategy over another. However, the Monthly Society Practice Guideline recommended to use the critical view of safety based on expert opinion, reference to the data in which the incidence of bioduct injuries was 2 per million of patients when CVS was used, which was lower than expected. By the way, the most common cause of bioduct injury nowadays is still be the misidentification injury. In other words, the cause has never been changed over the course of 25 years since introduction of the critical view of safety. So my question is, why it is supposed to be corrected, right? And my answer is, there is nothing wrong with the critical view of safety. However, there are some points that need to be clarified to avoid bioduct injury. Why critical view of safety was used as a goal? What if the injury occurs while we are performing dissection to achieve the critical view of safety? Understanding the relation between the dissection and the critical view of safety is important. Let's say that CVS could not be achieved without dissection. However, injury may occur at any point during dissection. I give you this example to compare the dissection and critical view of safety. In this situation, if we are looking for two zebras without getting close, we cannot see it clearly. We need either walking or running. However, the lion is waiting for its prey. Most of the time, we survive, but sometimes we may end up as a victim because we have always been taught to look for only the zebra, but not the lion. Somehow, I found that Be Safe Landmark gives you a good mapping. With a naked eye, you have a chance of seeing any part of viaduct in 77%. By looking for viaduct, we suddenly increase our awareness. This is key to understand that during cholecystectomy, our goal is to landmark the viaduct, not the gallbladder. The second area is that there are accepted situations in which the critical view of safety criteria will never be fulfilled. For example, those patients who have more than two structures in the hepatocytic triangle. In this figure, there are three structures. In such cases, the true cystic artery can be localized by the cystic lymph node. Then one artery was left untouched, and it turned out to be a small hepatic artery running back to the liver. Here is another case with more prominent of size of the hepatic artery. Injury to this artery can lead to significant amount of bleeding and potentially the ductal injury while hemocoagulation was performing. In some cases, the third structures may be an aberrant duct, and only by anticipating their existence will prevent our patient from sustained injury like this. A combination of aberrant duct injury as well as the common duct injury. Here is the last situation when the critical view of safety is not possible to be attained, and only by the matter of time before we realize that the danger is in front of us. However, it is extremely difficult to make a decision not to complete the cholecystectomy because most surgeons are trained to complete the cholecystectomy by achieving the critical view of safety. In this circumstance, Professor Strasberg proposed a three-step roadmap for preventing bioduct injury. And we are here, the second step, recognizing the danger and knowing when to stop. In other words, the infection point. And this decision is very rare among surgeons, depending on their experience. Therefore, I would like to bring an old saying to ensure you that sometimes the best surgeons are who knowing when to stop or not to operate. Referring to the latest series of subtotal cholecystectomy as a bail-out procedure, the most common reasons for infection point are listed here, including those with marked inflammation in the hepatocytic triangle and the fusion of the gallbladder to the bile duct. Another evidence from Delphi consensus suggested that the situation in which when to stop including impacted gallstone in the influence of the cystic duct and the common hepatic duct, and also the fibrosis and scarring in the callous triangle. All of these are clues for recognizing the danger. And then you select to perform the bailout procedure. Here is what I clearly use as a landmark for viaduct. The lateral edge of the hepatorenal ligament starts from the duodenum up to the cystic hyalopare junction. This line is theoretically the viaduct or the extrahepatic viaduct. Let's see this video. This situation, the critical view of safety is not possible to be attained by the impacted gallstone. The first step is to lysis the adhesion around the gallbladder and evaluation of the anatomy. And here you see the impacted gallstone are last stone at the cystic and the common duct junction. And not to interpret that the cystic duct, because this line is along the line of the hepatorenal ligament, so it was the common viaduct. Then the fundus first was used combined with the subtotal cholecystectomy. The key is not to dissect the hepatocystic triangle in this here by the impacted gallstone. In this case, the gallbladder can dissect it off the cystic plate without injury. At this step, before we open the gallbladder, prevent contamination is very important by pressing gauze under the liver surface and under gallbladder and preparing for endovac to retrieve the gallstone. After complete transect the gallbladder, 1 centimeter of the cuff is relieved. This is important to prevent injury to the ductal injury. Now is evaluating the cystic duct opening from the inside, and in this case, we cannot identify the opening of the cystic duct. So the reconstitution subtype was chosen. Two interrupted sutures were used to close the stump. Here's another case when the critical view of safety is not possible to be attained after repeated attack of the acute cholecystitis in morbid obesity patient. The first laparoscopic view, you can see severe adhesion around the liver and the gallbladder. With subsequent lysis adhesion started from anterior abdominal wall. And it is important not to use electrocautery when it is supposed to be some area of the intestinal structure. And at this point, you can see that there is no hilar structure that you can see, with the marked distension of the gallbladder and the early cholecystic abscess. Now, the prevention of the contamination was placed. Gallbladder was inside from the fundus. Suddenly, after opening of its wall, pus came out. At this point, only a small gallbladder lumen was seen. Now we can start to remove gallstone into the endo bag. Then proceed to remove the gallbladder wall. After wide opening of the gallbladder wall, you can see a large impacted gallstone, and it can be removed without contamination by this setting. The evaluation of the gallbladder lumen revealed that there is some bile fat. It is important to leave 1 centimeter cuff of the gallbladder to prevent injury. So, outer part of its wall can be removed as much as possible. In this case, if you see bile reflux from the internal cystic opening, then the fenestrating subtype was selected. Intracochlear suture to close the internal opening was now carried out. This is the last case that I consider to be the most difficult case. Let's see if you agree or have any point to discuss later. You can see adhesion around the gallbladder, especially at the highlight area. So my tip is to notice the anatomical landmark, including the falciform ligament, the umbilical fissure, and the hepatoduodenal ligament, and started the dissection from medial to lateral, closing to the liver capsule. However, at this area, you need to be aware of the duodenum or even the colon. It can be attached to the highlight area. At this point, we see a structure that should be a colon attached to the gallbladder. This is the hepatic flexure of the colon. So sharp dissection without electrocautery was selected, and see if there was any fistula to the gallbladder or not. And in this case, there was no fistula. You can see that the highlight area is full of the adhesion and attachment of the duodenum to the liver segment 4. The rectal cautery at this point should be used as less as possible. Here is the attachment of the duodenum to the liver. And now you start seeing some ductal structure or the gallbladder-like structure. However, anatomical orientation cannot be achieved at this point. It looks like a gallbladder. However, after a period of time of dissection, I question myself that the critical view of safety is impossible to be attained. And at that time, my answer was, is it not sure? I'm not sure. Is a critical view of safety can be attained? And it may look like gallbladder. However, it is located along the epidural ligament. So infection point is reached in this case, and I was prepared for prevention of contamination because the well-arm procedure was selected. The evaluation again before opening of any structure, and you can see this area in the cardiac crochet and the epidural ligament edge along the right side. This is the posterior portovertical. So the first incision should be above at this area. This case was the contracted gallbladder according to the lipid episode of the biliary colic and acute cholecystitis. The gallbladder is shrunken and retracted to the gallbladder fossa, and sometimes is the pull of the hilar structure to up to the gallbladder fossa, like in this case. After removal of the gallbladder, the stem was evaluated for any retain of the stone, and I reviewed that there was no stone. Then it was closed by intercalateral suturing. And I believe that we need to teach when to reach the inflection point and to teach more about the bell-arm procedure to collect the situation when the critical view of safety is not possible to be attained. And with simple question, is it possible to safely achieve the critical view of safety? If your answer is either no or I'm not sure, then the inflection point is reached. Remember, the best surgeon must recognize the danger and knowing when to stop and knowing how to finish the operation safely as well. Thank you.
Thank you very much, Dr. Nanak. Nice video and great presentation. I totally agree with you, Dr. Nanak. Prevention is so important, and surgeon must learning about bailout procedure. Dr. Theraton, do you have any question?
Okay. From the audience, now there is no questions from the audience, but I absolutely agree with you that if critical view of safety, if not possible to achieve the belt out or subtotal or partial cholecystectomy is one of the great solutions in the difficult case. So I have some questions for Ajahn Nanak. In your opinion, do you recommend any special additional preoperative imaging to see any anatomical variation in the cases with suspected with difficult LC or the intraoperative cholangiogram or ICG? Is it work in your experience?
Okay, do you hear me? Thank you for your interesting question. So the question is, do we need to do the preoperative imaging for detection of any variation, right? This is a very important factor for doing laparoscopic cholecystectomy in especially a difficult situation. Detection and anticipating this variation would be very helpful to increase your awareness and of course decrease the chance of the injury. However, in terms of the cost effectiveness, there is no recommendation regarding this issue. What I always do is, if you have done any of preoperative imaging, use it to prepare your operation as much as possible. So if there are any variation, you can miss it. That is my practice.
Okay, and another question, is there any difference in trocar or port placement or any special instrument that we have to prepare pre-operatively before we face the case with difficult cases?
Okay, for the second question, do we need to set the different port position? This is also an interesting question. And I think it's very useful to switch your right hand port to 10 to 12 millimeter. In this setting, if you need to place any surgical gauze or laparoscopic suture, they are immediately available to you, especially for breathing events that you may not expect it before the operation. You may not have time for preparing. So it would be great if we prepare it beforehand, I think.
Thank you for your comments.
Okay, the last question. What are your recommendation if the injury to the bile duct was occur in the new surgeon in the practice? If it occur in the emergency setting and that bursting event, should they repair or by themselves, or what are your recommendation?
Okay. The question is, if you detection of the bile duct injury intraoperatively, do we need to repair it ourselves, right?
Yes.
Okay. In this question, the first thing is important to detect it intraoperatively, because most of the time the primary surgeon could not detect it intraoperatively and detect it later in the postoperative period. In that case, early repairing could not be possible. So detection of intraoperatively is good. But however, from the data that study that show that repairing of bile duct injury by the primary surgeon with less experience may result in a recurrent stricture or not a good outcome in the long term. And even if you to do repairing with yourself or repairing, the outcome may even worse. So the only important thing is that detection and then referring them to the expert is better. Thank you.
Thank you, Dr. Nanak.
There is another question from the audience. Her question is, When do we consider for the frozen section to rule out the gallbladder cancer?
Okay, thank you. This is also an interesting question because most of the time the difficult cholecystectomy are full of the adhesion and thickening of the gallbladder. In that case, we cannot define whether it's only the chronic inflammation or the gallbladder cancer. I think it's especially important to detect it preoperatively and have an exact plan in the preoperative period. So you do not have something surprised intraoperatively. You have to plan it before. And if you have surprisingly found it in the intraoperatively, I recommend to do the frozen section, especially in the case of Malice syndrome, because some of the gallbladder cancer may present like a Malice syndrome. Another part that you can notice is the surrounding finding like a enlarge of the lymph node. This is especially found in the gallbladder cancer. That's my question, my answer.
Time is large. If there are no more questions for Dr. Nanak, thank you so much. Have a nice day and thank you for joining us. Okay, let's move to the next one. And may we remind our participants, if you have any questions for our speakers, please post them in the Zoom box. Okay, we're preparing the question for the speaker. Okay, let's move to the next, Dr. Chewatanakornkul.
Our next master that will give us the wonderful talk is Ajahn Pawan Chansanrod. Ajahn Pawan Chansanrod, he got his MD degree from Chulalongkorn University and Thai Board of General Surgery from Prince Songkla University, Thailand. He was trained his fellowship in MIS from Min Cheng General Hospital, Taiwan, and UCSF, California, USA. Now he is the senior consultant and the chief of MIS unit, Department of Surgery, Queen Sirikit, Naval Hospital, Chonburi. Ladies and gentlemen, please welcome Dr. Pawan Chansanrod.
Sorry. Thank you, Dr. Chewatanakornkul, for your kind introduction. Good afternoon, everyone. First of all, I would like to thank the MESDA committee to give me this great opportunity to share my experience in this fantastic conference. Our topics in this morning is very important and wonderful. This is very great opportunity for me to hear from all the experts. My talk today is about critical view of myopectoral orifice. I will summarize all the important anatomical knowledge and the step to achieve the anatomical view of the laparoscopic inguinal hernia repair. Can I have my presentation, please? Hello everyone. Today I will talk about the critical view of myopectoral orifice for safety and efficiency of laparoscopic inguinal hernia repair. Inguinal hernia is the disease with long history. Hernia surgery has been documented since the 15th century in the Egyptian papyrus. In 18th century, after introduction of anesthesia and antiseptic, all kinds of operations had been developed, and that was the era of the repairing hernia under tension. In 19th century, after the discovery of the synthesis polymer, the tension-free repair was more popular and has been the mainstay of inguinal hernia repair until recently. In 1975, Dr. Reeve and Stopper proposed the successful treatment of the pre-peritoneal space repair technique for inguinal hernia repair. Few years after, this concept was modified with the minimally invasive approach and became the first report of laparoscopic inguinal hernia repair. From that point until now, the laparoscopic inguinal hernia repair has been more popular. And from Hernia Search Group International Guideline for Groin Hernia Repair, the laparoscopic inguinal hernia become the accepted standard treatment for groin hernia. The main expected outcome for all inguinal hernia repair are lowest recurrence and lowest chronic groin pain. There are many factors related with recurrence which can categorize as patient factors and technical factors. You can see all technical factors can be prevented by the good practicing and good surgical technique. As the statement that everyone might already heard by Sir Ashley Cooper, he mentioned that hernia surgery requires a greater combination of accurate anatomical knowledge with surgical skill. So the understanding of anatomy is the necessary knowledge of inguinal hernia repair. The myopectoneal orifice of Frouchet has been proposed since 1956, which is the area that can have the groin hernia. The medial border is the rectus abdominis, and the lateral border is the psoas muscle. The superior border is transversus abdominis and internal oblique muscle, and the inferior border is the pectineum ligament. In laparoscopic approach, we will clearly see the myopectoneal orifice in the posterior view that make us more understand the pathophysiology of the groin hernia and the way to fix it. Before starting the step of critical view of myopectoneal orifice, we need to understand all the anatomy of the groin. I will briefly review and update the anatomical knowledge of the groin area, including 9 layers of abdominal wall, 2 spaces of the pelvis and inguinal area, and 5 important fossas for inguinal hernia repair. The 9 layers of abdominal wall start from skin, subcutaneous fat, superficial fascia, including campus fascia and scapula fascia, the innominate fascia, the inguinal ligament or external oblique aponeurosis, the internal abdominal oblique muscle, transversus fascia, the preperitoneal space, which lie between the superficial parietal layers and the deep visceral layer, and the peritoneum. You can see the difference of the thickness and the character of the superficial parietal layer and the deep visceral layer. And there is a potential space between the superficial parietal layer that attach the transversus fascia and the deep transversus fascia. And this is the holy plane for dissection in laparoscopic inguinal hernia repair. If we go to the right plane, we will find a vascular plane and safe from others important structure. The right plane is showing as the green line in this picture. You can see if we go too deep or too superficial, we will face with the small vessel. And even the main structure like vas deferens and the inferior epigastric vessels. The two important spaces are the retial space, also called retropubic space, and the brow space or retroinguinal space. At first, retial space is the name that called the extraperitoneal space, which located posterior to symphysis pubis and anterior to bladder. And the brow space is the preperitoneal space lateral to the retial space. But from the understanding of the layer of abdominal wall, we know that there are differences of the characteristic of the deep transverse fascia, which more adhere to the superficial layer in the brow space and rarely seen in the retial space. And the superficial parietal layer, which lie above the content of the spermatic cord, make a new concept of the retial space. This picture is the clear explanation of the difference of abdominal wall layer between the retial space and the brow space. So now the understanding of retial space might change from the picture A to the picture B. With this anatomical knowledge, we can do the dissection more precise and safe. After we understand the layer of abdominal wall and the space, we need to know the whole inguinal area, which can be divided by the inverted Y to be 5 triangles. This new concept of inverted Y and 5 triangles, which proposed by Dr. Marcelo, makes surgeons more understand the step of operation to achieve the critical view of bioperitoneal orifice. The inverted Y consists of the inferior epigastric vessel, vas deferens, and gonadal vessel. The inferior epigastric vessel is the important structure which all surgeons need to identify before starting the lateral dissection. The gonadal vessel and the vas deferens are two important structures which we need to preserve and identify for assuring that no any hernia sac left in the spermatic cord. The inverted Y divide the space to be 5 triangles. Start from the medial triangle, which stay above iliopubic tract between the inferior epigastric vessel and the border of the rectus muscle. This area is the Hunchback's triangle, which is the area that can have direct inguinal hernia. Next is the lateral triangle. This area above the iliopubic tract, lateral to the inferior epigastric vessel. The triangle is the area having the internal ring of the inguinal canal. Any visceral content with the peritoneum go through the defect in this area is the indirect inguinal hernia. The next triangle is the femoral triangle. This is the small area between the lagunar ligament and the external iliac vein, which is the area of femoral hernia. When we dissect this area, we might have seen the anatomical variant of the large vessel called corona mortis. The corona mortis is an anatomical variant of arterial or venous anastomosis between the external iliac and the obturator system of vessels. The size vary from small, like 1 mm, to larger than 4 mm. So we need to do carefully dissection when we are doing medial space or femoral space dissection. The next two triangles are the area that we have to carefully dissect and avoid to apply the traumatic fixation device on to prevent further complications. The triangle of doom is the area between the vas deferens and gonadal vessel. It contains external iliac vein and artery and the part of genital branch of genitofemoral nerve. The step of dissecting peritoneum down is very important before placing the mesh, and it's usually involving this area. The last triangle is the triangle of pain. This triangle is the area lateral to the gonadal vessel, having genital branch of genitofemoral nerve, lateral femoral cutaneous nerve, anterior cutaneous branch of the femoral nerve, and the main femoral nerve. The triangle of pain area are also involving the 1 to 2 centimeters above the inguinal ligament and 2 centimeters around the ASAS, because the nerve will line not only the area that we see. The denervation of the nerve go through the abdominal wall and pass this area as well. So this is the area that might have injury if we apply the traumatic fixation device on it. These are all 5 triangles that we will do the dissection and placing the mesh to cover all the defect area and having enough mesh overlap distance for all laparoscopic inguinal hernia repair. And what is the critical view of myopectoneal orifice? Beginning with the proposal of the critical view of safety concept in 1995 by Professor Starsberg. The critical view of safety concept is to reduce the incidence of biliary tract injuries in laparoscopic cholecystectomy. In 2017, Professor George Dias proposed the concept of critical view of myopectoneal orifice to maintain the safety and efficacy of MIS approach to inguinal hernia repair. And the definition of the critical view of myopectoneal orifice is the appropriate exposure of the anatomical area that must be attained before placing mesh during laparoscopic robotic inguinal hernia repair by the appropriate step. This is the critical view of myopectoneal orifice of the both groins. From this point, I will list the steps to achieve this view for TEP approach. And for the APP approach, we can also apply the idea, but in the different step sequence. This is the recommended step approach for achieving the critical view of myopectoneal orifice. The 9 steps including identify pubic tubercle and Cooper ligament, identify the direct hernia, medial space dissection, identify the femoral hernia, lateral space dissection, identify the indirect sac, identify the cord lipomas, prepare for mesh placement, and the last step is placing the mesh. The first step after entering the retromuscular space is identify the pubic tubercle. When we found the pubic tubercle, we will know the way of dissection, and we recommend to dissect across the midline, and then dissect to find the Cooper ligament. The next step is identify the direct hernia. If we use balloon dissection, we can see the anatomy through the balloon. When we do balloon inflation, this is the infraepigastric vessel of the right side, and this is rectus abdominis, so this is the hatchback triangle. So we keep inflating the balloon and we see the anatomy. This is the rectus abdominis. This is the infraepigastric vessel of the left side. So this is hatchback triangle of the left side. So this is the normal. And when you see on the right side, you will see the direct sac. So if we use the balloon dissection, we can see the direct inguinal hernia as the first time. This is the direct inguinal hernia. During dissection, if we find the unusual fat around the hatchback triangle, we need to clear the fat out in order to clearly see the floor of the hatchback triangle. When we remove all the fat out and we see the hatchback triangle, sometimes we can see the medial defect, and this is the direct inguinal hernia that needs to be fixed. The next step is the medial space dissection. We need the space at least 2 centimeters between the Cooper ligament and pubic symphysis and the bladder to facilitate flat placement of the medial and inferior edge of the mesh toward the space of lesions, thereby avoiding mesh displacement caused by the bladder distension. The next step is identify the femoral hernia. We need to do the dissection between the Cooper ligament and the iliac vein to identify the femoral orifice and rule out femoral hernia. You have to remove the content here until we clearly see the femoral orifice. This is the Cooper ligament and this is the external iliac vein. After we remove the content out, we will see the femoral orifice very clear. And when we dissect in this area, we have to be very careful about the corona mortis. This is the arterial corona mortis and this is the venous corona mortis. The next step is the lateral space dissection. We do dissect peritoneum lateral to the cause element laterally, beyond the anterior superior iliac spine. I normally mark the location of the ASIS before surgery to confirm the point of dissection. And we do the lateral dissection in the right pane under the transverse fascia here. So if we go to the right pane, we also call the holy pane, we will see the vascular pain and no bleeding. And when we do the lateral dissection, we will find the triangle of pain around here. So we might face the nerve, but we don't have to identify all the nerve to avoid the injury. So the next step is identify the direct sac. This is the most difficult step for the beginner. We have to dissect the indirect sac and peritoneum sufficiently to revitalize the cord elements. This step is often not complete, especially in a small surgical field. To ensure compliance with this requirement, continue to dissect until the cord element lie flat. And we have to see the peritoneal lining along the way, so we can make sure no any sac come into the spermatic cord. And we have to dissect the peritoneum down and make sure not have the part of peritoneum go through the inferior border of the mesh. The next step is identify the cord lipoma. The lipoma of the cord usually stay on the lateral side of the cord element. The misdiagnosis of cord lipoma is the reason of the persistent symptom after surgery. Most of lipomas do not require removal, but should be placed above the mesh to help prevent mesh rolling upward. After done all dissection, the next step is checking around again to make sure that we have enough space to place the mesh covering all the defects and enough mesh overlapping area, and have space for applying the fixation device if it indicated. We have to make sure all peritoneum lining is dissected down from the radius space and the broad space, and no residual sac left in the chord element. And the final step is placing the mesh. We can do this step only when the previous steps are complete. And the recommended mesh size is larger than 10-15 centimeters. And we have to place it without crease or fold. You can see if we dissect the space large enough, we can place the mesh very easy. And the mesh will cover all the defect area and will have enough the mesh overlapping length. After we place the mesh and we'll finish the operation, we have to ensure that its lateral inferior corners lie deep against the wall and doesn't roll up during the space deflation. All these are the recommended steps for achieving the critical view of myopectoral orifice for TEP approach. And for the APP approach, we can use the same concept but in a different sequence. In TEP, we normally do medial area first, followed by lateral area and central area. But for the APP, we normally do lateral area first, followed by medial area and then central area. We use the same concept of all these steps to do both TEP and TAPP. That's all my talk for today. The key messages of this presentation are: understanding the anatomy is necessary for all types of hernia repair. Applied clinical anatomy is helpful for performing the perfect operation. And critical view of myopectoral orifice for inguinal hernia is the strategy to prevent complication and achieve the good outcome. Thank you very much.
Oh, very wonderful lecture, Dr. Pawan. Your lecture is very clear for the critical view of the myopectoral orifice, and the abdominal wall is a lot of the layers that we can see from the laparoscopic view. So I have some question. In your practice, I saw from your video, I see the E-tip technique, right?
That video is TEP.
TEP, okay.
And that's standard TEP technique.
Okay, I have a question for the beginner. The abdominal wall have a lot of the layers. So how do you teach the new surgeons to overcome the learning curve of the TEP technique? And what's your advice for a new practitioner?
All right. Thank you for your question. That is a very interesting question. First of all, the TEP, unlike the TAPP, because the TEPs, we go into the new space that we usually not familiar with. The TAPP approach, we go into the intra-abdomen. So all surgeons kind of familiar with this anatomy. But the TEP, we go to the new space that's some kind of challenging for the beginner. My recommendation is understand the anatomy first. You have to know what you're going to face, and then you practice with the experienced surgeon that can guide you for the anatomy. So that can short your steep of learning curve. And if you want to learn anatomy for the TEP approach, I recommend the ETEP approach. Which is the move the optic trocar upward a little and to the lateral side. And this technique will give you more surgical feel, and you can see and learn the anatomical structure very clear with the E-tip technique. And my teacher, Dr. Siripong, said that the TEP is some kind of difficult to learn, but it's very easy to master. When you know all steps when you understand the concept of the TEP. It's very good technique for you.
Another question for me.
Yes, please.
Do you have a trick for get into the lateral dissection? Because there are a lot of the layer. And what is your landmark for get into it?
Yes, thank you. I'm looking for the inferior epigastric artery first. That is the very important landmark, because if you didn't see this structure, you cannot go to the right way. And then you find the peritoneum lining. The peritoneum, because you can see the peritoneum lining clearly than other layers, and keep just above peritoneum lining, and you will see the light and clear space. You go to that space. That space is below the TF, and that's what we call the holy pain that I just saw in the video. I think that is the key to go to the right pain and no bleeding.
Very wonderful video clip. Okay, Dr. Chewatanakornkul, do you have any question from the floor, from the box?
From the box and the audience, there is no question anymore. Okay, very thank you to Ajahn Pawan for this very informative lectures and answers again. Your talk absolutely inspired all newbies for hernia surgery in the correct way. Yeah, and finally, we want to emphasize that the critical view of safety in cholecystectomy and myopectoneal orifice are very useful and very crucial for all surgeons. These are our good chance to learn from both experts. Finally, we want to thank you to MESDA again to give us to have a chance for this session moderator. And it's my great honor to be the co-moderator with you, Ajahn Ling Piyanan, one of the rising star young MIS surgeons.
Okay, let's move to the next session, clinical session about the bowel, left side and right side colon. Please, Dr. Siripong.
Okay, I'm back to stage again now. Good afternoon again. I am Dr. Siripong Chewatanakornkul. So for the afternoon session, I will be your moderator, and my co-moderator is Dr. Attaporn. Dr. Attaporn, good afternoon.
Good afternoon.
Okay, are you ready?
Yes, of course.
Okay, so our
First
session.
of all, I would like to congrats to the MESDA and also Professor Siripong, Professor Voraboot for your excellent meeting. I learned a lot from, non-clinical meeting this morning and also clinical about cholecystectomy and hernia. And I think the next topic is also very interesting about, majority of the laparoscopic colorectal surgery, especially for beginner, should start from the lap right hemicolectomy or lap left hemicolectomy before you do the TME. Therefore, and today we have a very expertise in this field to talk to you how to do it correctly and precisely, right, Professor Siripong?
Yeah. So many times as a mentor, I found that the beginner have an obstacle to setting the exposure before making a surgery. That I think that is a very pain point for beginner. So today we have two topics about the critical view of safety in left side colon surgery and also have right side colon surgery. So Dr. Joe, would you please kindly introduce our invited speaker?
Yes, the first speaker, Professor Ichiro Takemasa. Professor Takemasa is a very well-known laparoscopic colorectal surgery. Professor is currently chairman of Department of Surgical Oncology and Science, Sapporo Medical University, and also he served as a visiting professor at many universities in Japan. Professor Takemasa is also the editor-in-chief and editorial board member of many peer-reviewed papers in his expertise. And ladies and gentlemen, please welcome Professor Takemasa.
Yes, thank you. I really appreciate inviting me to this meeting. Please start my video. Hello, everyone. I am Ichiro Takemasa from Sapporo Medical University. My dear thanks goes out to Professor Kitano and all faculties of MESDA for this opportunity. My topic of today is critical view of right-sided colonization and its current status in Japan. My COI. First of all, I will spend the next few minutes to show you current status of MIS for CRC in Japan. Growing social demands for quality of life coupled with dramatic advances in development of devices has led to the widespread introduction of the laparoscopic surgery as MIS for CRC. Now you can see the data from latest questionnaire by JSS in 2019. Penetration rate keep increasing and MIS for CRC come to account for around 80% in Japan. Next, you see other data from National Clinical Database. This data shows the penetration rate of MIS are around 50 to 70%. Interestingly, LAR, which is considered a more difficult procedure, has a higher prevalence than right hemicorectomy. This data is applied to mortality and complication in Japan by NCD. Green represent right hemicorectomy and blue for LAR. Complications more often occur in LAR than in right hemicorectomy, while mortality occurs more often in right hemicorectomy. This indicates that right hemicorectomy is not an easy procedure, and once a complication occurs, it can be a major one leading to a mortal death. As you know, the basic concept of surgery for right-sided colon cancer is complete mesocolic excision, CME, with central vascular ligation, CVL, focus on oncological clearance, which was established over a decade ago from England. This report have found that EFS can vary by as much as 10% depending on the success or failure of CME. The benefit of adjuvant chemotherapy in stage 2 or 3 colon cancer is only around 5%, which shows how important it is to perform CME in surgery before the benefit of adjuvant chemotherapy. The difficulty in standardizing the procedure in right hemicolectomy and anatomical vascular variation is thought to be preventing the spread of its MIS in Japan. Arterial variation of the colon was mentioned in Aneta, the well-known textbook. Understanding these vascular anatomies and variations are important to radical lymph node dissection. We summarize an arterial variation in the ICA, RCA, and MCA, which are important landmarks in right hemicolectomy. Most of our reports about these anatomies were studied in cadavers, so the sample was relatively small. Then we tried to examine the arterial variations with CT angiography with larger samples. This is the data focused on the RC variation from preoperative evaluation by CT angiography on almost 800 patients with ascending colon cancer. We classify them into 4 patterns according to the origination of the RCA. The pattern of the RCA divided directly from the SMA were most common, the left side, and approximately 30% were lack of the RCA, the right side, and if it exists, 20 from the MCA and 10 from the ICA. The anatomy of the colonic veins are also very important. It was revealed that the variation in the veins were much more than that in the artery using a small number of cadavers. They revealed that the GCT was present in 70% and the lack of an RCB was 60%. We also summarized the variations in the MCB using CT angiography. The most common pattern of the MCB was a direct flow into the SME, that was 70%. But there was also 20% flow into the DCT, and layering into the jejunal vein, IB, or splenic vein. Therefore, it is preferable to understand the venous variation before surgery. There had been no report on the 3D relation between the artery and the SMB. Thus, we also studied this anatomy in preoperative evaluation with 3D volume rendering multimodal imaging. Particular attention was paid to root of the RCA and an ICA relative to the SMB. The ICA was identified in our cases. It passed the SMB posteriorly and anteriorly. The ratio was 3:2. Interestingly, if the ICA passed the SMB anteriorly, RCA will pass the same side as the ICA, while the ICA passed an SMB posteriorly, the RCA will pass the same side in only quarter, and will pass an anteriorly in 3/4. This was the lymphatics around an SMA and an SMB in an autopsy reported by Professor Sato. Main route is along the SMB proximally. I'd like to start with the video clips of conventional laparoscopic surgery. First case I show you is ascending colon advanced cancer. Tumor located mid-ascending colon and the operative diagnosis was T3 under stage 2. I perform a little peritoneal approach to dissect the right colonic mesentery caudally to cranially. First, with the head position, the assistant forceps were used to lift up mesentery ventrally like a matador. The peritoneum of the iliac mesentery root was explored and the incised parallel to the right common iliac artery. Always keep enough tension to give caudal to cranial dissection between the lateral peritoneal fissure and the posterior of the right mesentery. The most important thing was just a dissection layer to the ventral sides, the duodenum and pancreas, and to make enough dissection space between the pancreas and the posterior of the right side colonic mesentery. Next, the right side colon and the ilium were moved back to the pelvis, and the terminal ilium near the appendix was tractioned ventrally and laterally with the assistant forceps to identify ICA and an ICB. The ICA was lifted ventrally, and the iliac mesentery was inside through a dimpling sign. At this site, the intestinal fault was thin and easily connect to the dorsal space, and made a mesenteric window, and then window was grasped with the assistant forceps, and the mesenteric dissection was proceeded centrally. We always expose the peripherally of the SMB first, and made a peritoneal incision cranially with the left border of the SMB as a landmark to separate the mesenteric fat from the small bowel mesentery to determine the base of CME. The SMB was landmarked, and you can see the landmarks, the SMB, and then export the ICB. This case is the ICA pass posteriorly relative to the SMB and cut, and mesentery was dissected near the RCA to complete the D3 dissection in the CME. Then the CME was completed by mobilizing the hepatic fracture with a head-up position, like this. To perform intracorporeal anastomosis in this case, the ilion first transected using the stapler, and then descending column 10 cm distal to the lesion was transected intercorporeal using the stapler. In this way, the resect specimen could be extracted through a 3 cm ventral incision, thus minimizing the incision. Functional end-to-end anastomosis were then performed intercorporeally, like this. Suture 2 points, and then cut here, and then move inside the stapler into iliac, and then ascending column, and then the first firing, and then closure with running suture, like this. Then second firing was performed, and 2 firing is needed. In recent days, the overlap method is often used because it is easier. This was the final view after dissection and anastomosis. The operation time was 110 minutes and the amount of blood loss was very small. Second case I show you is transverse colon advanced cancer. Tumor was located near hepatic fracture of transverse colon, and then preoperative diagnosis were T3 and 0 stage 2. The lateral peritoneal approach was completed, and mesentery was dissected from the dimpling sign. So you can see dissected around the root of the ICA and ICB here, and then expose the left border of the SMB here, and you can see in the green spot it's an ICG, the preoperatively using the endoscopy, direct injection into the mucosa, then ICG injected. In this case, the IC passes in front of the SMB. So we expose the ICA. Then you can see the root of the ICA here, just thoroughly exposed. Make the between spaces, then the ICA and then the front of the SMB, like this. And then cut the ICA between crypts. Since this case was an advanced cancer of the transverse colon, it was necessary to dissect the root of the MCA for CME. The dissection line was adjusted from the left margin of the SME to the duodenum towards ligament and the lymph nodes in front of the SMB and the SMA were dissected completely. The important thing here were to use assistant forceps to firmly tension the mesentery of the transverse colon and deployed like a matador. In this way, our artery arising from the SMA could be recognized as the artery of the transverse colon, and our artery is cut at the root. After the MC was cut at its root, the SMB was further exposed cranially. The pancreatic vein was preserved, and all veins falling into the SMB were cut at the root. The many veins were existed in this case. Last vein was cut between clips. This was final review after dissection and anastomosis. The operation time was 140 minutes and the amount of blood loss was minimal. This is a meta-analysis between CME and non-CME, which was conventional procedure in Western countries. It showed that CME is superior not only in short-term outcomes such as post-operative complications, but also in the number of the dissected lymph nodes, 3-year and 5-year OS and DFS. Recently, a series of papers have been reported from various countries showing the superiority of CME by big data analysis of population base. This was a report from Denmark in 2019, published in The Lancet Oncology. The similar report from China, which was a prospective, non-randomized, double-blinded controlled study, was published in the Annals of Surgery last year. This is a meta-analysis between the laparoscopic CME and the open CME. Interestingly, it showed that the laparoscopic CME is superior not only in short-term outcomes such as mobility and motility, but also in long-term outcomes such as local and distant recurrences. This is a Chinese randomized controlled phase 3 superiority trial named LILAC, which was Leeds dissection versus CME in right hemicolectomy. The primary endpoint of this trial is 3-year disease-free survival. Secondary endpoints including 3-year OS, post-operative complications, mortalities, and rates of positive central lymph nodes. Short-term outcomes of LILAC was published in The Lancet Oncology this year. Almost 1,000 patients were included. Post-operative complications were similar between groups, and no deaths occurred in either groups. Of the intraoperative complications, vascular injury was significantly more common in the CME group. Metastasis in the central lymph node were detected in 3% only in the CME group. So this also claims the CME generally seems to be safe and feasible for experienced surgeons. Next, I'd like to show you a short video clips of a single-port laparoscopic surgery, SPLS. The patient is 60-year-old woman. The tumor located in the ascending colon. So you can see the green is the tumors and the red is the positive lymph node, and in the vascular variation you can see the first head down position and decubitus position, and an idiom and ascending column, move to cranially, and export the root of the iliac mesentery, and then inside the root of the mesentery, they called retroperitoneal approach, and then dissection was kept to maintain to cranially, and then make the space between the in front of the pancreas and then behind the right mesentery, and then the flat position, and move to the lymphadenectomy. They grasped the pedicle and then made a window, and then grasped the window, and then proceeded to the centrally, and then identified an SMB, and then ICA was exposed, and then encircled the ICA. This case, ICA pass anteriorly relative to SMB. They cut between the crypts first, and then incision of the mesentery, and then expose the root of the ICB here, and then cut between crypts of this root. And here's an adducere lymphadenectomy was completed. And lastly, head position, the fully mobilization of hepatic fracture. Completed. The operating time 2 hours with a small blood loss, and 1 month later, the almost score is invisible. We had reported the feasibility of CME by SPLS versus conventional lab for each side column by match the case study with the largest number of the patient in surgical endoscopy in 2014. We have also reported a long-term outcome of CME as a propensity score match case study in this year in 2017 that 3-year DFS and OS were equivalent to conventional lab in all pathological stages. Robotic acid lab surgery providing a stable 3D operating field and intuitive procedure with multiple joint forceps is also extremely innovative. Finally, I'd like to show you video clips by Lars. So then similar approach. Then in the conventional laparoscopy, and then SPLS, and then Lars, we choose the same procedure, that is latent peritoneal approach. So expand the right mesentery within a fourth third arm, and then make a space in front of the duodenum and pancreas, and then behind the right mesentery, like this, with good counter traction. The very precise procedure was possible to using the Lars. No bleeding, very precise. And here you can see, make a space the pancreas and the vein. It's a very precise procedure here. It's possible. And the green spot is an ICG, is maybe in a lymph node here, maybe in a station 3 lymph node. And then inside the mesentery through our dimpling sign, it's not easy to access the dorsal space as made in a small window like this. And then inside the mesentery, along the left border of the SMB here, the precise dissection around the SMB and then the dissection was proceeded to the cranially. The CME was performed with precisely with robotics, and you can see complete mesocolic excision was performed here. And then you can see then ICA here and next to ICB. In this case, ICA partially relative to the SMB here. Identify and the cut between groups the ICV first and then ICA. And in this case, this lymphadenectomy need to cut the right branch of the middle colic artery, and then inside the mesentery along the root of the MCA, peripherally to its branch, and encircle the root of the MCA, and then identify the bifurcation, and you can identify the right branch and the cut between the crypts. And it's important that this lymphadenectomy was performed is behind the MCA, the complete dissection along the SMB was performed. And then the lastly, the accessory right colonic vein was circulated and clipped and then cut between crypts. This was the final view of the dissection. No green spot. The D3 lymphadenectomy for the CME was completed. Thank you for your kind listening.
Okay, thank you for your wonderful and beautiful presentation. Any comments, Dr. Cho? Or question?
Yes, Professor, congratulations for your excellent talk. I have two questions. The first is, do you perform the CT angiography or venography every case before you perform the DT lymphadenectomy? Is it routinely performed, CTA or CTV?
Yes. And now the Japanese government and reimbursement was covered in CT angiography relatively. So then every cases we do the CT angiography. But it is useful to understand the anatomy of the right side column by preoperative CT angiography because the vascularity of the right side column is highly variable. However, the most important thing is the intraoperative findings because it may not be possible to visualize all the small vessels. In particular, there are small venous veins around the GCT or the MCB. And if they are handled carelessly, they may lead to bleeding.
Yes. And my second question for the ICG node that you demonstrate from the injection, how long that you are waiting after injected the mucosa, and how long the node already seen by the fluorescence scope?
Okay, best timing is 5 hours before the surgery to watch the lymph node mapping. So then the ICG used to the blood flow of the anatomic site is just the 20 second before, but then the watching lymph node mapping or lymph node vessels. So 5 hours before, and if the injection in 7 days before, you can not may check the ICG. So we can see the lymph node mapping intraoperatively with NIR mode with ICG. So injection in within 7 days before the surgery, and then 5 hours past is best point, I think.
Okay, Professor, I have one question.
Yes. Yeah.
I just wonder that your technique is so meticulously dissection. So I think that does the robotic surgery that you use in your video add the advantages more than the laparoscopic surgery or not?
Yes, that's a very good question. So in Japan, now there's a reimbursement only for the rectal cancer only.
Mm-hmm.
So now is paid money for the patient by themselves. However, in a U.S. situation, minimal invasive surgery for the colon cancer, they often keep decreasing, and the laparoscopic surgery peak out. So the peak is 2015. So after 7 years ago, decreasing. So only robotics keep increasing because transverse. If the tumor located in transverse, this lymphadenectomy around the MCA is very difficult. So especially in a big patient and obese patient. So robotic surgery makes it very precise, and then a fixed operative view was gained with robotics. So then in the near future, in Japan, maybe are covered, reimbursement covered, and colon cancer. So maybe in the near future, keep increasing and robotics for the colon cancer.
Thank you so much. I think that is really quite a nice demonstration of a various surgical technique, single port surgery, also conventional and also the robotic surgery. Thank you so much, Professor.
Thank you. Thank you very much.
So we move to the next. I think this is the last topics for today conference. The next topic is critical view of left side colon surgery. Will be presented by Dr. Trung. Dr. Trung, he is head of digestive surgery department in Choi Rê Hospital, Vietnam. I think we have met before, I think more than 5 or 6 years ago. So please welcome, Professor.
Yeah, welcome. Nice to see you all. Yeah, very nice to see you.
Yeah. Okay.
So
would you please start? Yeah.
Yes. I will share my PowerPoint. Okay. So hopefully that you guys is not so tired. But the meeting, so the conference, so interesting. I attended since this morning on the basic things for the surgeon, and we just hear Professor Takashima presenting so wonderful presentation about the critical point views in the right colon resection. So I would like to first of all to thank you, the organizer, for give me this opportunity to firstly attend this conference, and hopefully that we will have the chance to see you many times again.
Yeah.
So I would like to share with you guys the topic of the critical views of the left side colon resection. I'm Dr. Lâm Việt Trung. I'm head of the digestive surgery department in Choi Rê Hospital in Ho Chi Minh City in Vietnam. So my presentation will have 4 parts. First is I will say an overview, the principle of surgery, and some guideline of treatment, and the technical point and in the left hemicolectomy. I would like to introduce a little bit about Choi Rê Hospital. We are the referral hospital in the south of Vietnam. And my department is the digestive surgery department. With we do both upper and lower GI, in which we did about 600 cases of gastrectomy for gastric cancer per year, and about just more than half is laparoscopic surgery, and about 100 cases of MIS esophagectomy, transthoracic and translaparoscopic esophagectomy, and all of them in MIS. And about colorectal surgery, he's going to perform about 800 to 1,000 cases per year, and in which 80% is MIS. And we also started the first robotic program in 2017, with just more than 500 cases from now. So we know that lap colectomy is a challenging operation. Actually, in the most common indication is for colon cancer. And besides, we have some indication is the diverticulitis or the ischemic colitis or the Crohn's disease. So my presentation today, I will focus mostly for the indication of colon cancer. We know that the complication rate of this operation is quite high. Appending to Pelino in 2018, the complication rate can be up to 25%, with anastomotic leak is 8%, which count for half of the perioperative death. The risk factors included the patient-related factors, and like obesity, comorbidity, or malnutrition, and perioperative management, the surgeon-related factors. So how could we improve this situation? So let's see about it. First of all, I would like to remind you about the principle of surgery for colon cancer. You know that the principle of surgery for colon cancer is the colectomy with en bloc resection of the regional lymph nodes and invaded organs if possible, like the abdominal wall or the small intestine included. And the lymph nodes at the origin of the feeding vessels should be examined, should be harvested and examined pathologically. And the recommendation is a minimum of 12 lymph nodes harvested should be applied. Minimum invasive surgery can be considered just in case that we have experienced laparoscopic surgeon, no contraindication for laparoscopic surgery, like no obstruction, perforation, or also advanced cancer. And the preoperative marking of the early lesion should be possible, and the thorough abdominal exploration. So that is the principle of surgery for colon cancer. So depending on the depending on the location of the tumor, so we can have the appropriate range of resection of the colon accordingly, that you can see it in the picture here. So, according to Japanese Society of Cancer of Colon and Rectum, CCR guidelines, so this section, lymph node section, will be classified in DO, D1, D2, and D3, depending on the invasiveness of the lymph node metastasis. Like with the lymph node metastasis positive or the advanced tumor, they recommended D3. So what is D1, D2, and D3? D1 is the lymph node section in pericolonic lymph nodes, mostly around the marginal vessels. You see that in this is the marginal vessels come along with the colon. And D2 is D1 plus intermediate lymph nodes. So those lymph nodes in the feeding vessel along the main vessels. And D3 is the D2 plus the main lymph node root of the main vessels. For example, the IMA or the left colic artery. And the distal and proximal resection margin recommended is at least 10 centimeters from the tumor borders. So that is the concept of the D1, D2, and D3 according to Japanese society. So Hohenberger is introduced the concept of CME, is a complete mesocolic excision, in 2009. And now it's become the standard for the advanced colon cancer. So I would like to emphasize this is for advanced colon cancer, not for the early cancer. That is the technique of sharp dissection of the visceral gland from the parietal gland. And the origin of the colonic artery can be well exposed and tied centrally at the origin to ensure a maximum harvest of the original lymph nodes. So you can see that the range of dissection in the CME is quite larger and wider than the D3 from the Japanese D3 technique. So what about the difference if the CME and non-CME? Beta Cell and college have compared quite a big number of patients, more than 360 patients with CME, with 1,000 patients with non-CME surgery for colon cancer stage 1 to 3. And they found that the DFS of the CME group is significantly higher than the non-CME group. So CME is clearly have benefit for the advanced cancer patient. But for between D3 and CME, at the moment, we did not find any comparative study between D3 and CME. Now I talk about the guideline for treatment for colon cancer. So with the colon cancer, resectable non-metastatic, we have to do the very thorough workup for diagnosis and treatment, and diagnosis and staging of the colon cancer. And for the resectable and non-obstructive, we can proceed with the operation with the unblocked removal of regional lymph node. But for the obstructing but resectable, we can have several options, or the one-stage colectomy with unblocked removal, or resection with diversion, this means colostomy or stent, depending on the case. So how can we choose what is the optimal treatment for the patient with obstruction? diverting colostomy or urgent colectomy with colostomy, or the urgent colectomy with immediate anastomosis or stenting. So those we have to see the whole picture with depending on the patient status, like how old is the patient, how is the patient national status, how is the comorbidity or the sepsis condition, what is the surgeon capability. We cannot do the advanced surgery with the patient with no experience, and with the how is the resuscitation condition of the hospital, and what about the economical condition. So I put this in because in some developing country, the economical condition is very important. Not all the patient can afford for the laparoscopic surgery or the surgery with staple, something like that. And this is, you can see this, the guideline of WSES in 2017 of how we manage the patient with colonic patient with obstruction. So we see it obstruction with left-sided colon. If the patient is stable, unstable, we can do the colostomy, or if the stable, then we can choose the anastomosis, resection anastomosis, or the Hartmann procedure, or put a stent as a bridge for the operation. And with the patient with perforation, the sepsis control is priority. And we have to control the sepsis status before performing the patient, depending on the perforation on the proximal side or at the side of the tumor. And how we prepare the patient is very important. If we would like to have the successful operation, we should have a good preparation. So that's preparation. We will follow the ERAS protocol, as you all know, that the nutritional support will be necessary for the poor malnutrition. And we recommended mechanical bowel prep recommended for the left-sided colon resection, because it can facilitate for the bowel resection and the anastomosis, and the prophylactic anastomosis antibiotic is recommended. Now I talk about some technique in the lap colectomy. Patient will be put in is very important for the lap colectomy, because if we do not have the correct position, the operation will be very difficult. We normally use the like this position with tilted slide tilted to the right, and head can be up and down depending on the what side we do it. Like why we do a head when you do the splenic fracture that take down, or if we can put the head down when you do the sigmoid dissection, for example. And the leg should be apart for the possible endoscopy or the insertion of the circular stabler for anastomosis. We use 4 to 5 trocars for approaching, normally 10 mm trocar for camera and the 12 mm trocar for dissecting and the stabler use. So some surgeons prefer this 5 trocar like this, but I myself, I prefer the 5 mm trocar in suprapubis position. And so by that, we can do the mini incision for the specimen extraction. Then surgeon should be standing on the right side of the patient with the cameraman, and the monitor could be put on the left side of the patient, either up or a little bit right, depending on the location of the dissection. Observation is very important. Firstly, when we do the checkout of the abdominal cavity for the possible peritoneal metastasis or the liver metastasis, or possible the concomitant lesions. And locating of the tumor is very important as well. We can do it preoperatively via endoscopy, the CT scan, and the barometer. But some case the lesion is early, small tumor, then another method should be applied, like endoscopic tattooing, by endoscopic tattooing or by clips So you can see here the image of the laparoscopic view with the injected tattooing with the ink, or you can do the intraoperative colonoscopy. Then you see here this picture is a laparoscopic view and the endoscopic view at the same time, and for locating the location of the tumor. So this is very important. If you're not sure about the location of the tumor, then you can make a mistake when doing resection. Thirdly is observation. We have to identify the important landmarks during the dissection. We have to identify the IMA, inferior mesenteric artery, the left colic arteries. Some variation of the left colic artery can exist. So the identified is very important. With the marginal artery, you know that the marginal artery of Drummond is sometimes we have 3 to 5%. We don't have the connection between the middle colic artery vessels branch with the left colic vessel branch. So in such a case, then we should pay attention. We also have to recognize where's the duodenum, the angle of tray, the inferior border of pancreas. So we need to locate it during the dissection of the splenic fracture. The promontory, when we approach to the splenic dissection, and very important that we have to identify the ureters, the left and right, and also the gonadal vessel come along with that. The dissection, we can choose the medial to lateral or lateral to medial approach. But I think that we can combine between the two approach depending on the situation. If the tumor is not obstructed on the field, then the medial approach can be applied. But sometimes we cannot approach to a medial approach, then the lateral approach can be performed first. So lateral approach with included the liberation of the toe fascia, and important that we have to preserve the deep subperitoneal fascia is in the gerotal fascia, the fascia in front of the fat layer of the kidney, and we will go up from the sigmoid point until the splenic ligament, and to do the splenic fracture mobilization. But the splenic fracture mobilization is not always necessary for all the case of left colectomy. It depends on how far we do the resection. And sigmoid mobilization is also important if we perform the for the anastomosis. So we do not have the tension anastomosis. And you can see in this picture the correct plan to do the dissection. So the correct plan is the plan between the fusion fascia of the toe and the deep supraperitoneal fascia. And you can, based on the ureter, the spermatic vessel or gonadal vessels, for like a landmark for identify during the dissection. And during the lymph node dissection and the vessel ligation, we can perform concomitantly at the same time with unblocked resection, and pay attention to the hypogastric nerve just below the inferior mesenteric artery when you do the lymph node dissection at the origin of the arteries. And when this is important that to injure this nerve. And finally, we do the resection and anastomosis. The intracorporal and right now is more surgeon favorite the intracorporal anastomosis than extracorporal anastomosis because of the invasiveness and development of the laparoscopic surgery and instrument can facilitate the surgeon to do the intracorporal easily and effectively. And most of the case, we can use the stapler for anastomosis, but sometimes we can do the hand seal anastomosis with the suture, but it will take more time and need the surgeon skill. A circular stapler or linear stapler depending on the location of the tumor. Most likely, if we do the lower, below the promontory, then circular stapler can be easily performed. But if the resection is above the promontory, so the remaining sigmoid is very long, that is impossible to insert in circular stapler inside. So the linear stapler, you can see here, is useful and the easy technique to perform. So that depends on how local tumor location, the patient status, the facility, and the surgeon experience and favorite. So this is, I just show you a little bit about the technique this is sigmoidectomy. So the traction of for the medial approach is very important to identify the plan of resection, to identify first where is the ureter, the gonadal vessels, in order not to injure it. So meticulous dissection is very important to get a clear view of the operation. You can use the energy device or the monopolar dissection, depending on, you can see it is the ureter, yes. And outside is the gonadal vessel. And we can proceed to dissection of the IMA. And we transected and ligated the IMA at the origin with clips. I would prefer the Hemlock clips and resection. And then we proceed to the IMV. So it's important that we have to see how is the vascularization of the descending colon, how is the vein and the artery and the marginal artery before making any clips. And this case, I preserve one branch. You can see here one branch of the vein of the left colic artery. And the lateral approach, lateral dissection is performed after the medial approach. The TME technique. So after that, the distal resection, then the tumor is was brought outside to make to put the angle in, and after that to make the intracorporeal anastomosis with double stapling technique. Okay. And the second video is I would like to show you the lap colectomy, laparoscopic lap colectomy. The patient with the T4A. So we identify the tumor. This tumor is very easy to identify. It's advanced tumor, T4A. And we will recognize it on the splenic fracture, duodenum, and the vein. The adhesion of the colon to the lateral border. So we do some lateral dissection first. You can see the ureter fascia. So it's sometimes difficult to keep the ureter fascia intact. And if we do the mistake to perforate it, we can correct it. We can correct it, the dissection. And then medial dissection. In this case, we preserve the IMA, and so we have to locate it, the origin of the left colic artery and left IMV, the vein. So we see the left colic artery and the vein here. So we can carefully dissect it and transect it. You can see this, the ureter, and we can proceed ligate the the left colic artery at the origin. So we sacrificed one segment, the first segment branch. And whole surgery, we can use it only the harmonic scalpel for the main energy device. The dissection go up to the border of the colon. You see that we're clamping the marginal artery, the most important, the very important artery supply, giving a blood supply for the descending colon. So we proceed into the splenic fracture, and we cut the colonosplenic ligament to liberate the colon in front of the caudal pancreas. The splenic fracture was completed and taken down. And you can see here the inferior border of the pancreas. And in order to make an CME, it's important that we dissect it on the mesentery of the colon out of the inferior border of pancreas. So we choose the location of for resection and of the colon and also of the vessel. Similarly, in this case, one small branch of the left colic vein is preserved with this branch of artery. So linear cutter is used for resection of the proximal end, and the specimen were put in the specimen bag. This is the special bag, the bag made in Cherry Hospital. This is not the original one. And we do the dental shape anastomosis with the linear stapler. And then the second stapler will be used to close the opening of the anastomosis. So we systematically close the peritoneum, which is open, to prevent any possible postoperative herniation, internal herniation. And we check the integrity of the anastomosis, and we take out the specimen out via the suprapubis resection. Incision, for example. Okay, so it's important that we have to recognize some common pitfall and how to prevent it. Like you can see the ureter injuries very rarely happen, but it did happen sometimes. Like in this case, you can see if you don't pay attention, and the harmonic scalpel can transect the ureter, half of the ureter. In this case, we have to reconnect it. And even with the lateral resection with the monopolar, with the hook, is sometimes very dangerous when we don't pay attention. So the torsion and counter torsion is very important. If we don't do it correctly and carefully, then the complication can happen. Even with the dissection of the inferior mesenteric artery, and we also pay attention cause injury to the small bowel just behind. Like in this case, you can see the monopolar scissor is used, and the small bowel was touched. Okay, and you know that this case in 5 days later, post-operative, and the surgeon did not suture it, and the patient have peritonitis due to the perforation of these lesions. So the other possible complication, including the spleen laceration when you have too much suction, and the possible the post-op internal herniation can happen, especially for the left colectomy. It may not happen more frequently in the low internal section, but the left colectomy, I always recommend it for suturing the peritoneum defect after the operation. So, in conclusion, we think that the critical views of left colectomy resection may include mastering well the principle of surgery and guideline management. And we have to understand well, not the anatomy, but the surgical anatomy during the operation in order to prevent any injury during the operation, and handling well the surgical technique as well as the incident, how to manage the incident during the operation. Thank you very much for your kind attention, and we're looking for your comments and discussion.
Thank you so much. Thank you so much, Dr. Tung.
Thank you.
Thank you.
Thank you very much.
So, any question, Dr. Cho?
Thank you very much for your excellent presentation, Professor. My question is usually for the left side colon, what is the antibiotic preparation? Do you use oral antibiotic or IV antibiotic for your current practice?
We follow the ERAS protocol with the prophylactic antibiotic. So normally we use the IV prophylactic antibiotic, the first cephalosporin, first generation cephalosporin before the operation. But for some case with the risk, and we can use the treating antibiotic for 5 days after the operation. So we always use the bowel prep, mechanical bowel prep for the colon cancer patient, except for the obstructing bed cases.
Thank you very much.
Yeah, you're welcome.
So I have another question, please. The second case that you show us, the tumor is located at the descending colon, right?
Yes.
So you decided to do as a sigmoidectomy, not left hemicolectomy, right?
The first case is a sigmoidectomy, but the second case is the left colectomy.
Yes, because sometimes I think that when the tumor located at the descendo-sigmoid junction, it is very difficult to just the way to do it in left hemicolectomy or sigmoidectomy.
Yes. I think that is very important, very interesting points that you propose.
Yeah.
Sometimes we don't know how to do it with such a situation, because if the tumor located in between the left colon and the submit colon, so in such a case, we will consider if it's advanced tumor, and then it's early tumor, and the tendency of how is along the submit colon. Normally with the Asian people, I don't know what about in Thailand, but Vietnamese people, the submit colon is quite long. So we can do the resection of the submit colon and liberation of the left colon, and we can do the intracorporal end-to-end anastomosis by linear stapler. But if the tumor is advanced and we have to do the high ligation at IMA, and we do have to do resection in the promontory, then the circular stapler, we often use the circular stapler.
Yes, that's
so it depends. It depends. Yes.
So that's a good point, because our circular stapler is reached only when we cut at the promontory of the sacrum, right?
Yes. And if we use the circular stapler, I think that the small size circular stapler, like 28 or 25, even 28 or 29, or even 25 is recommended. If we use the big one, then we cannot approach it.
Okay, thank you so much.
Yeah.
Any comment from Dr. Ataporn?
No.
So I think today we cover on the topic in left side colectomy. Thank you so much,
Yes.
Dr. Trum. Dr. Trum, and
You're welcome.
hope to see you again soon. Hope to see you
try
again.
You right, yes.
Thank you so much. So I think today we cover on all the topic already. In the morning we cover the soft skill, I think, which is very important topics. So now I think we in the field of the MIS surgery, we need not only to do a deliberative practice, but we need to build up our skill to a new skill set like cutting and editing the video, editing the manuscript for research, and practice English conversation also. Okay, I would like to hand it off this conference to a closing recap to Dr. Vitun. Dr. Vitun, please.
Thank you, Siripong. On behalf of MESDA, I would like to thank Professor Kazuma and Professor Takemasa from Japan and Professor Lam Viet Trung from Vietnam and the other over 10 surgeons from Thailand. Actually, I would like to very much thank you to our course director, Professor Siripong and Professor Voraboot, who take a lot of time to select a pretty good surgeon and speaker and to make this event happen. And actually, we have to thank UC Delta and ABET Association that provide us the support, including the Olympus and Medtronic as well. So this is just another page of new academic activity that we just opened up to see whether or not our members of MESDA and the young generation of surgeons around the Macro region may be able to join to share the experience. And I think after the finish of COVID-19, I suppose sometime probably next year, I hope all of us will come together to see all together, to chit and chat and coming to see all together again. So thank you very much for all speakers again, sponsorships, and also the participants. And see you next time from MESDA. Thank you so much.
Before we leave, I think I would like to invite all speakers to open the camera on your notebook. So we also like have a screen capturing and send you.
Yes, group photo.
Yeah.
Okay,
group photo.
Yeah. On the screen.
Right, group photo.
Group photo, please.
Okay, opening the camera.
Smiling.
Your camera, please. Everybody. Dr. Dan Ak. You be there? Professor Ikichiro. Very nice view of Japan, Fuji, right? Okay.
Yes, you can see
my dog is in Mount Fuji.
Beautiful in Vietnam as well.
Okay, smile. 1, 2, 3. Snap. Okay, thank you. Thumb up, please. Thumb up, please. Thumb up, please. Okay, thank you, everybody. So I would like to thank you, our back office and our audio visual together to be here today. So see you again next time.
Yes, thank you.
Bye.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Have a good weekend and stay away from COVID.
Yeah, don't forget to do the evaluation form, please. All of us.
Okay.
Okay. Bye-bye.
Thank you very much. Yeah, see you soon. ขอบคุณครับอาจารย์ครับขอบอาจารย์วิทูลครับ
ขอบคุณครับอาจารย์ซ้อมร้องเพลงเหรอครับไปไหนแล้ว
Good afternoon to all the audience. It is my honor to be here with you, and I would like to thank the organization committee,
and the course director, Professor Siripong and Professor Voraboot. So my first question today is why the laparoscopic cholecystectomy and bile duct injury is still be a debated.
อาจารย์ไหนครับเนี่ย
อะไรครับพี่พี่คุยกับผมอยู่ป่ะครับ
ไปไหนครับเนี่ยปิดหน้าทำมิดชิดเลย
ดูคนไข้ครับพี่ดูคนไข้พี่
ร้องเพลงเหรอ
ยังไม่ถึงเวลาพี่ร้องเพลงเดี๋ยวค่อยอีกทีนึงพี่
ใส่ทอดสดไหม
งานเยอะพี่
ใส่ทอดสดไหม
พี่ถ่ายทอดสดใจเย็นพี่ไม่พี่ congratulation ด้วยครับผมว่ามันน่าสนใจ
พ่อนายแหละคอนเทนต์นายอย่างนั้นเนี่ย
เวอร์